Dear ladies and gentlemen, esteemed colleagues and honored guests. Good evening everyone. Ramadan Kareem. I am Sarna Kamal working in EyeQon Hospital as an optometrist and currently I am the president of the United Optometrists Forum. Welcome to the opening ceremony of the international webinar on World Optometry Day. Commemorating the invaluable contribution of the optometrists worldwide. Today, as we gathered from virtually every corner of the world, we celebrate the invaluable strides made in the field of the optometry and reaffirms our commitment advancing eye care for all.
Good evening everyone. Ramadan Kareem. I am Palniappan Lakshmanan, working as optometrist in Al Zahra Hospital, Dubai. I am also Vice President of United Optometrists Forum. On this auspicious occasion, we reflect on the profound impact of optometry in promoting vision health and preventing the blindness. Optometrists serves as guardians of vision, empowering individuals to experience the world with clarity and precision. From diagnosing the refractive errors to managing complex ocular conditions. Their expertise is instrumental in enhancing the quality of life for millions of people.
As we navigate the challenges of the rapidly evolving world, the role of optometrist becomes increasingly vital. With technological advancements and demographic shifts reshaping the landscape of the future, our collective responses prioritize the eye health has never been more urgent. Through collaboration, innovation, and advocacy, we can ensure that eye care remains accessible, equitable, and inclusive for all.
Today's webinar acts as a platform for knowledge exchange, collaboration, and inspiration. As we engage in insightful discussions, share best practices, and explore emerging trends, let us seize this opportunity to strengthen our professional networks and reaffirm our optometry commitment to excellence in the practice. Today, we are incorporating a photo booth in our webinar platform, which will allow the attendees to take selfie under different countries' background.
That's correct, Bala. It's exciting features actually. Now, let's call the chief guest of this webinar, Dr. Majin Sinjab from Dr. Sulaiman Al Habib Hospital, Dubai, to say a few words. Over to you, sir.
Hello, everybody. I'd like first to thank you very much for your kind invitation and my congratulations on the happy Optometry Day Worldwide 2024. And thank you very much for organizing this event and for inviting me to open this the ceremony of this great event. Now, during the coming 3 to 4 minutes only, I'm going to emphasize on the importance of collaboration between the optometrist and the ophthalmologist in many parts and in many aspects, particularly in the keratoconus aspect, because I am the founder of the International Keratoconus Society. My name is Professor Mazen Sinjab, working in Dr. Sulaiman Al Habib Hospital in Dubai. Collaboration between optometrist and ophthalmologist is very important in the field of keratoconus. It is not only in terms of contact lenses, because some people may think that we refer for contact lens fitting and that's it. Actually, collaboration is on many levels, starting from the diagnosis until the solving the challenges. We ophthalmologists face many challenges in keratoconus. First of all, keratoconus, it is a very common disease, especially in the Middle East and many parts of the world. And the prevalence of this disease or the incidence is up to 4 or even 5% in some countries, which is a very high percentage. And you know that it starts in usually in early adulthood or even in childhood. And whenever it starts in the childhood, it is more aggressive and more progressive. One of the challenges is refraction determination, and we really appreciate your kind efforts in helping us to determine the refraction of the patient in order to make our patients happy in their glasses. Actually, we face as well challenges in contact lens tolerance and in choosing the best treatment option. And we all know that the queen of the options is the glasses, while the prime minister is contact lenses. However, we have many other options like corneal cross-linking, customized laser vision correction, intracorneal ring implantation, CARES, inlays, fake IOLs implantation, and the last option that we always try to avoid is keratoplasty. That's why I founded the International Keratoconus Society, which is open not only for ophthalmologists, it is for optometrists and all allied ophthalmic professionals. And I would like to thank you very much for always collaboration and for supporting in treating the patients and in bringing happiness to the patient. And of course, I would like to invite you all as optometrists to attend the first World Keratoconus Congress that will be held in Dubai on April 19 and 20. So we are very close to that, less than 1 month. And of course, I would like to invite you as well to visit my website, sinjabacademy.org, and visit the platform iOpt, which is devoted to optometrists and allied ophthalmic professionals, where we can work together and where we can collaborate more and more. Thank you very much. And I wish you in this event the best and more collaboration in the future. Thank you very much.
Thank you, Dr. Mahajan, for being with us today and your never-ending support towards optometry community. Now, I would like to hand over to Devkani, who is present in South Africa studio. Over to you, ma'am.
Thank you, Swarna. Ramadan Kareem to all of you. Myself, Kani, optometrist working for Sheikh Khalifa Medical City, and I'm also a secretary of United Optometrists Forum. I would like to call upon Mr. Obi Malop, optometrist from South Africa, country known for its breathtaking landscapes and wildlife safaris. He will take us through unlocking the growth potentials in your optometry practices. Over to you, sir.
Good day, dearest colleagues. My name is Obi Malope, an optometrist based here in South Africa, the motherland. Firstly, thank you so much for the invite that was extended to me. It is a complete honor and a privilege to be able to represent my continent and more specifically my country in being able to add value to this wonderful organization and platform. Happy World Optometry Day. I'm fully convinced that this day is going to be filled with phenomenal presentations that are going to add so much value and impact our wonderful industry the world over. I was tasked with speaking on unlocking the growth potential of your optometric practice. And when I was researching the topic and looking at what will be the best way to be able to bring this presentation forward, I summarized it under the subheading of advanced business strategies that your optometric practice can be able to implement this year and beyond. So, 3 things that I want you to just keep at the back of your mind as we go through this presentation for the next couple of minutes. Number 1 is, what are you currently doing in your business right now or in your optometric practice to elevate or enhance the patient experience and maintain peak performance levels? Well, there are 3 ways in which you can go about doing that. Firstly, you have to figure out what is the attractive appeal of your optometric practice. The best way to go about that within your practice, get everyone to have a piece of paper and actually write down on that piece of paper what the attractive appeal is of your optometric practice. It will be interesting to see whether or not your team shares the same views as you do. And if not, then discuss it amongst the team and be able to come up with, let's say, 3 things that define your practice's attractive appeal, and then center everything that you do around that attractive appeal of your optometric practice. Secondly, you have to go out of your way to expand your clinical competency skills so that you are in a position to offer patients something that is different than what other practices within your community are offering your patients. Your patients need options, and when they start thinking of those options, does your practice come to mind? And lastly, we have our optometric practices with either optometrists, optical dispensers, and administrative staff. We don't spend enough time investing in developing the sales skills within our optometric teams so that the capacity to be able to sell the products that we are selling or that we are providing can increase. And that's how you go about establishing different or practical ways in which you can expand or elevate the patient experience and maintain peak performance levels in your practice. Let's take it a step further. If you have to analyze your business right now, where does your optometric practice fall in? Are sales declining? Staff losing motivation? Business has reached a plateau recently as compared to the past few years? Or are you experiencing average results? Or perhaps you just achieving the results and the performance that you had set out to? Or are you currently experiencing exponential growth? So this is a question that you have to make it personal to you and be honest about your answer, so that if you're currently experiencing decline, then you will then focus on activity strategies that will help you get out of that decline. If you're experiencing exponential growth, then the question then becomes, what did you specifically do that resulted in that growth? How can you maintain it? And what do you then have to do in order to secure that growth to take place the following year and the year after that? So this is a question that you have to be honest to yourself when answering. And so let's unpack some key components of your practice that I believe are very important in taking your practice to the next level. Number 1, actually all 3 of them, these strategies are centered around the consumer or the patient. The reason why I say consumer is that we believe that there are different types of people that walk into your practice. There are people that walk into your practice for the very first time needing eye care services, but then there are those we refer to as patients. Then you've got customers, people that have been to your practice before, perhaps once, and they're now going to be coming to your practice for the second time for their eye care needs. And then we've got the third group, which is clients. These are the people that have been coming to your practice year after year for all their eye care related needs. And so we group them under the consumer. And so the 3 consumer strategies that your practice should implement going forward. Number 1, individualize the patient care. Don't treat everyone the same. Literally, make everyone feel like they are the most important person to walk into your optometric practice at that moment. So personalize the patient care that you are providing. And you can only do so by probing the people that are coming to your practice so that you can understand what are the expectations, what are their requirements, so that you can line up your management solutions and the experience that they're going to get with that which they deem to be important to them. Secondly, never compromise when it comes to service delivery. You have to determine what is the standard of excellence in your practice, and does every single person on your team agree to that standard? And then ensure that you go out of your way to give consumers that standard. If you fall short of that, do something about it. Thirdly, go out of your way to build a trust relationship between yourselves and the consumer. If people trust you, it makes it easy for them to go with whatever it is that you recommend as their management solution. If they don't trust you, it just makes that process of them going with what you recommend a lot more difficult. Remember, trust leads to loyalty. Loyalty leads to repeat business, and that's what you want. You want people moving beyond coming to see you every 2 years to coming to see your practice every year. But you want to get to a point where you're separating the diagnosis from the management solution. And what do I mean by that? You want people to be buying from you at regular and consistent intervals, even though their prescription might only be changing every year or every 2 years. You want them to be having multiple management solutions. That will not happen if they don't trust you. So focus on these 3 things. Number 1, individualize the patient care for each and every single person that walks into your practice. Number 2, set a very high standard of service delivery, that it has to be excellent and nothing else. And thirdly, ensure that you are going out of your way with each and every single person that comes to your practice by building that trust with them. And trust sometimes is how you respond to queries. Trust sometimes is built on how you handle different situations that give the consumer confidence that they are at the right place and that you know what you're doing. And so the eye care practice that you're building, simplify the buying process. Also, as much as you're personalizing or individualizing the care that you provide, also personalize the recall system. Get feedback from your clients, broaden your brand positioning, and most importantly, invest in your team. The mistake that a lot of practices make is that they invest in, of the optometrists, they invest in themselves and they invest in the practice, but they forget to invest in the team. So ask yourself, that staff member that has been in your practice for the last 5 years, what new skills have they been exposed to or developed so that they can elevate your practice to the next level, simply because they're able to do that which they were not doing 5 years ago. So very, very important that you focus on these 5 aspects in the eye care practice that you're building. Next, remember earlier on, we mentioned that the consumer, there's the patient, the customer, and the client. So what will wow the patient, that person who comes to the practice for the very first time needing eye care related needs, is how you are informing them and educating them about their eye health and eye management that will be required. Whereas the customer, that's person that comes to your practice for the second time, and you want to wow them. So the wow factor for this person is creating a worthwhile experience at that second visit. Whereas with the client, the wow factor here is them seeing your practice innovating, providing consistent value every single time they come to your practice. So these are the wow factors for the different types of consumers. And so this slide here, and we will share the slides with you guys, we just go deeper in terms of the characteristics that define the patient, the customer, as well as the client. So we will share these slides with you so that you can get a better or a deeper understanding of what characteristics define the patient, the customer, and the client, so that you then know how to best approach each and every single one of them at any given point in your practice. We have got this thing that we call the evaluation strategy. You have to have a plan of action in terms of when do you follow up with the patient, when do you follow up with the customer, when do you follow up with the client. And so we do a summary here of when you follow up with each and every single one of those individuals. And so a take-home message on this section, remember, for you to elevate your practice, you have to elevate the consumer experience. Trust, empathy, and loyalty should be your focus with every single person that walks into your practice. Thirdly, ask yourself, what makes you stand out? Is it your team? Is it how your practice looks? Is it the value that you are giving them or providing patients or customers or clients with regards the competency skills that you are having in your practice? How are you communicating? Do you customize and personalize the manner in which you communicate with each and every single person that comes to your practice? And most importantly, once a person has already purchased something from your practice, what are the aftercare service protocols that you have in place in ensuring that a person is satisfied with the business that you've already provided them and the products that they've already purchased from your practice? So basically, these are the important factors that you need to take into consideration going forward in your optometric practice. And yeah, that was definitely the presentation for today. I'm fully convinced and confident that all the other presentations that are going to be following this one are going to be super, super amazing and add value to your optometric practice. Once again, thank you very, very much for the opportunity to be able to contribute to this amazing day of webinar conferences today. Thank you very much, everyone. And make sure to connect with us across all social media platforms. We are on YouTube, we are on LinkedIn, Facebook, Instagram. Please do connect with us, and we look forward to meeting you all in person one day. Thank you.
Thank you, Mr. Obimalo, for that eye-opening talk on emerging trends in optometry practice. So now I'm in UAE, standing in front of Museum of Future. Let us move on to our first session of the evening, the Lens Fit Mastery. Now I would like to call upon the first speaker, Mr. Sridhar Swarna, to talk to us about contact lenses for pediatric patients. Over to you, Mr. Sridhar.
Hi, you are muted, Mr. Sridhar. Can you unmute yourself?
Hello. Yeah, I'm so sorry. I'm so sorry. It was my mistake. And yeah.
It's fine.
My
Carry
name is,
on.
yeah, am I audible now?
Yes, clear.
Yes. My name is Sridhar Swarna. I'm an optometrist and a specialty contact lens consultant, running my own practice by name Sight Savers Optics LLC from Dubai. And I wish all the optometrists across the globe a very happy World Optometry Day. And we are all the proud soldiers against the blindness. You know, we stand for the first defense against the blindness. So today we are going to discuss on the contact lenses for the pediatric patients. And in today's presentation, we are going to understand the importance of contact lenses for children, especially the infants, and and an age group under 10. So why I said age group under 10 is age group under 10 are always are protected by the parents, so they require extra care, extra concentration by the parents. So as we all know that contact lenses are the best option because they give you a full field of vision in comparison with the glasses, and sometimes the only option for kids suffering from nystagmus, anisotropia, aphakia, myopia control, and high refractive errors. So in fact, especially the infants with uniocular or binocular aphakia should always be considered for RGP or soft contact lenses. So, because, especially the RGP lenses are easy to handle, and, the insertion and removal is quite easy. But, sometimes, the children may be not comfortable with the RGP lenses. So in these cases, we can consider the silicon hydrogel lathe cut lenses, and they can be customized completely between a diameter of 12 to 15 mm, any base curve or any base cover or power. And Pediasite is one of the finest designs for the RGP lenses. They offer a very specialized design for the pediatric patients, and it is made by advanced vision technologists from United States. And they offer very, very specialized RGP designs. And I had fantastic success with the RGP contact lenses on children. And Silsoft from Bosch & Lomb is very popular, and Orbis from Swiss Lens offer great silicon hydrogel lenses for infants. So for children under 6, the parents, especially mothers, should be taught insertion and removal of lenses. Infants require, very specialized techniques in handling the lenses. And needless to say, hygiene plays a very, very important role in controlling the infections. And, since I have a very limited time, I'm just directly going into some videos, which would be self-explanatory. So this is how an RGP lens is inserted in an infant. As you can see, the lens is placed on the lower lid and just slid into the eye. It's very, very easy. So the most important thing is, controlling the movement of head and hands of the child. So it's very, very important. And this is how a silicon hydrogel lens is inserted. As you can see, it is folded from the center and just slide it under the lower lid and just close the eyes. And the removal is more or less similar to the RGP lens. Just use the lower and upper lids, both the lids, press it against and against the edges, and it just comes out, just pops out very easily. So it requires a bit of practice. So this is a case of a 3-month-old boy with aphakia in left eye. So the only way was to fit a contact lens to save him from slipping into amblyopia. So we opted for Pediasite RGP lens. And due to its smaller size and easy handling, and the power was plus 25.25 spherical with a diameter of 9.8 and base curve of 7.3. And it was pretty challenging because the moment when I've shown these lenses, this lens to the parents, they were really intimidated, looking at the rigid RGP lens. So they were really scared. So I really spent a lot of time in counseling them and explaining them and how important is RGP, because it offers a great crisp vision. And then finally, I have involved the mother in training her and handling the lens. And we had a fantastic result with this boy. So since the child is too young, so it is we opt for only objective correction. And most important thing is to correct the vision for intermediate, because the viewing distance for the child is very, very close. So it's very, very important to correct for the intermediate distance. And the child was brought up for follow-up a couple of times, 2 or 3 times. And we made some small changes in the power. And the child got really, really adopted to the lens, and he was very cooperative. And for about 1 year, 2 months, I was following up, and the whole family have moved back to India now. So hope the child is doing pretty well. Now, yeah, this is the final lens, plus 30, 9.8 base curve, 9.8 diameter and 7.03 base curve. So it looks pretty decent, and yeah, there is no, there is a mild apical clearance, and the movement of the lens is decent. Safwan is very cooperative boy, and the over refraction is minus 2.5. So sorry, minus 4.5. So sorry, 4.75. So we are going to fit. I mean, we're going to correct the power, and we are going to order for a new lens. Amazing child. Thank you very much. Beautiful boy was 3 months old.
So this has slight movement, sir.
Movement should be. So we taught the mother on how to handle the lens using a plunger, and she mastered the art of handling the lens, and she was very good. I mean, and the boy, initially was crying, but he was very good. He got really adopted to the lens. Now, this is another boy, a 9-year-old boy with binocular aphakia, nystagmus, microcornea, and retina degeneration with poor vision, was presented for contact lenses. He was referred by an ophthalmologist, and he was using bifocal glasses with plus 12.5 with an addition of 2.5 in both eyes, and the distance vision was very bad, less than 660. And he's from Bangladesh, and no one has offered to fit a contact lens because I don't know, because of the non-availability, I don't know. So his cataract surgery was done about 7 years back, and and he was having esotropia with the above mentioned conditions, and we have fitted with silicone hydrogel in both eyes plus 1550, and with a diameter of 11.7, base curve of 8 in right eye and 8.2 in left eye. And we gave him +3 spherical glasses for reading. The above mentioned conditions, and we have fitted with silicone hydrogel in both eyes. This is a 9-year-old boy with bilateral aphakia and nystagmus, microcornea, and he has got degenerative changes in his retina. He was referred by an ophthalmologist.
Sorry, Mrs. Sridhar, you have 1 more minute.
With the 62% water content silicone hydrogel lens. I started a minute late. Cut plus 15.5 in both eyes. Right eye base curve is 8, left eye base curve is 8.2, and both eyes the diameter is 11.7. So it's about. You can see his nystagmus, vision, has come under control. 6/16. The moment we have in both eyes given the lens. Glasses, the nystagmus was very obvious, and it was really. And this is the same boy wearing glasses now. Wearing glasses, and you can see that got esotropia, and there was an obvious nystagmus with the glasses. Bifocals, and you can see there is a bit of nystagmus. There is a esotropia, convergent squint. Look here, look here, look here, look here, look here. ऐसा सीधा हाथ को देखो. Very good, very good. So apart from high refractive errors and anisometropia, contact lenses should be considered as the first option for myopia control with day lenses or orthokeratology, and in combination with atropine ranging from 0.01% to 0.05% would be very effective in controlling the myopic progression. And most importantly, hydrogen peroxide is highly advised to avoid a solution-induced toxicity. In case of non-availability, we can advise the multi-purpose solution, but ensure that a non-preservative saline is used to rinse the lens before the insertion. So a regular checking on the cornea using fluorescent, we can find out if there is any staining. So an optometrist should never be scared of fitting contact lenses in infants, because as we can really save the children from slipping into myopia. So if you have any questions, please feel free.
Thank you, Mr. Sridhar. That was a wonderful talk. And now I would like to call upon Mr. Tanyos Gargas for the third talk of the session. and he is from Lebanon, known for the famous historical landmarks and Christian beaches. Mr. Tanyos will take us to growing contact lens category. Over to you, sir.
Yes. Hello, everyone. Good evening, good afternoon, and good morning from around the world. And happy Optometry Day. My name is Tanyos Georges. I'm the training manager for Amico Middle East. And we are proud to be sponsoring this event. It's always a pleasure to be part of such events. And as you know, our company is the exclusive distributor of EyeQon contact lenses products in the Middle East. And again, it's a great honor to be part of this webinar and to share with you some information regarding growing the contact lens category in general with the support of the new technologies available in the market. So just our topic is basically how we will be
sorry to
able
interrupt.
Yes,
we cannot see
yes.
your PPT and we cannot see your video also.
You cannot see my video? Okay. Please double check now. Is that fine?
Yes. Yeah.
Okay, perfect. So as I was saying that our main objectives whenever we are eye care professionals in any practice is how to provide the best satisfaction for our customer. Because when our customers, they are satisfied, definitely the business is gonna grow. That's the logic for any business. And in the upcoming 18, 19 minutes, we will see how contact lenses will be able to deliver a satisfied customer and in parallel, a growing business. The data is showing that, imagine 10 out of 10 contact lens wearers, current contact lens wearers, they are saying that contact lenses will enhance their lifestyle. They are happier whenever they have the chance to have eyeglasses and contact lenses. And I always say, in all my events, in all my trainings, that eyeglasses is the right hand for the patient who needs vision correction. It's his right hand. It's a priority, is the first choice. But he will be struggling only by having eyeglasses. So he needs another option. And the only other option that we can provide to eyeglasses wearers is contact
sorry, Mr.
lenses.
Tanyos. Can you please
Yes.
share your presentation? We couldn't see your presentation.
It's fine now? Can you see my screen?
Yes. Yeah, it's okay now.
Okay, perfect. So as I was saying that 10 customers out of 10 patients, they are happier whenever they are using contact lenses. And eyeglasses is the right hand for the customer. But eyeglasses by itself, it's not enough to do everything that he wants in life. Just take a small example if he's playing sports. So eyeglasses in this particular event, in this particular activity is not enough. So he needs an alternative. And whenever we are offering them, offering our eyeglasses wearers, we are offering another option, which is contact lenses. They are happier and they are saying that contact lenses with their eyeglasses, they are having a better life, it's enhancing their lifestyle. So whenever we are offering contact lenses to our customers, we are satisfying our customers more by just offering contact lenses. But what it's doing to our business, imagine dual wearers, that means wearers that they are wearing eyeglasses and contact lenses, they are the most valuable patient to your business. Why? Because they are 3 times more valuable. So each customer who is wearing eyeglasses and contact lenses equal 3 customers who are getting only eyeglasses from your practice. Why is that? Because customers who are wearing contact lenses also, they buy eyeglasses as often as the only eyeglasses wearer, but they buy them also with the higher price. because imagine they are able to see what they are purchasing. Imagine the high powers people, if they are not wearing contact lenses, they cannot see what they are purchasing, and they are always relying on other people to choose for them. But when you fit them with contact lenses, they will be able to see what they are purchasing, and there they will be able to buy the higher price. Also, contact lenses, they visit the stores more frequently. And as we all know, that the more traffic in your practice, the healthier is the business. While eyeglasses customer, they visit your stores only 1 time per year or maximum 2 times per year. We can see that contact lens wearers, they visit your stores at least 4 times per year. And those customers, they become more loyal, they trust you more because they are able to see you more. And whenever they are visiting you, they are purchasing other products than only eyeglasses. The last part, which is the sunglasses business. We all know, and all the studies is showing, that when the patient is being fitted with contact lenses, in their lifetime, they purchase more of sunglasses for 2 reasons. First, because they have the freedom to purchase any type of sunglasses, whether the mask one, the big one, the curved one, which the eyeglasses only customers, they were not able to purchase, while the contact lens customers, they are able to purchase any type, any model of sunglasses they want. And secondly, because they visit the store more and they see more collection. So they have the freedom, and because they are repeating their visit to your stores, so every time you have a new collection of sunglasses, they are able to see them in person, and whenever a customer is visiting the stores more, they will be able to purchase more. So the first takeaway of this slide, I just want you to just imagine and to understand, and we all know, I'm just repeating what you already know, but this is very important message, that we need to fit more people in contact lenses, because by just offering contact lenses to the customer, we are helping them to enhance their life, and we are helping ourselves to have a growing business. But the problem is, globally now, the penetration on contact lenses is very low. Only 10% of the eyeglasses customers, they are wearing contact lenses. That's a very low percentage. And we need, with your support, to grow this, because the study is showing that 50% of young eyeglasses users, that means young between 12 to 40 years old, people what they do a lot of activities, they need an alternative for their eyeglasses. 50% of them, they are interested in wearing contact lenses. But the problem is, whenever we ask these people, why you are not wearing contact lenses, they are reporting that my eye care professional didn't talk about contact lenses with me, didn't offer me contact lenses. So the big problem is our customers, they rely on the eye care professional to start the conversation about contact lenses. And in parallel, whenever we ask the eye care professional, to whom you sell eyeglasses, or to your eyeglasses, to whom you sell and you offer contact lenses, they respond for whoever asks us. And that's the problem. So we are waiting as eye care professional for the customer to ask, and the customer is waiting for the eye care professional to offer. And this conversation is not happening quite enough. So we need to be the leader with our eyeglasses customer to open the discussion with them and to tell them that you are also eligible with your eyeglasses to start wearing contact lenses. And we show them the benefits and how contact lenses will enhance their life, and for them to take the decision if they want to start using contact lenses or not. But at least by offering, by telling them that we are eligible and you are eligible to wear contact lenses, now it's in their mind, even if they don't start today, but they know in the future, if they start a new activity, if they had any difficulties wearing eyeglasses in in any sports, in any activities, in any occasion, they will understand that my eye care professional, he can offer me an alternative, a support for my eyeglasses, and the name is contact lenses. So please, we need to start this conversation with our customers. And we don't need to always wait for them because they are either afraid, they don't know, or nobody talked to them. So in order to grow any category, we need to drive demand. We need to be leader in driving the demand, but also we need to reduce the dropout because there is a lot of customers that are already wearing contact lenses and they don't have a good experience for different reasons. So as you can see in this bucket, we need to fill it with new customers, but also we need to stop old customers or the current customers of leaving the category. So how people, they start using contact lenses, it's not by chance. People now, they are well educated and they are browsing, and the number of optical stores in any country, in any of your countries, is becoming more and more, and the competition is getting tougher and tougher. And that's why 40% of any customer, when they want to purchase anything, and especially contact lenses, they say that I will start with a certain optical store. It depends on the quality of the information provided by that practice on the contact lenses. So in order to gain a new customer, you need to make sure what kind of information we are delivering to these customers. Are we treating them as just consumer? Are we treating contact lenses as fast-moving product, or just you can get it out of the shelf? Or we're just taking some time sitting with our customers, explaining the advantages of contact lenses, explaining about the new technology, giving them all the information so they can trust us more and start purchasing from our practice so they will become a loyal customer in the future. But in contact lenses, there is two main concerns. The biggest concerns in wearing contact lenses is the dry eyes and the discomfort, because there is a lot of customers, they report dry eyes symptoms or discomfort whenever they are wearing contact lenses. And this is a big problem. So we need to be careful what type of contact lenses we are offering, and we are still offering old technology, or we are making sure that we are offering our customers an upgraded opportunity. So the studies is showing that 80% of our customers, 80% of our consumers, they are open to be upgraded, and they are open for paying more money if the new contact lenses will solve the dryness issues or the discomfort issue or the redness issue or using eye drops. So any problem that the customer is facing, we need to understand this problem and we need to solve their problem, and they will be more loyal to us and they will be ready to get the new contact lenses, even if it's with a higher price. But the problem again is only 4 out of 10 of the eye care professional globally, they are doing this upgrade. So whenever there is a new technology in the market, only 40% of the eye care professional, they talk about the new technology with their consumers. And 60%, somehow, I don't know the reason why, but they don't open this discussion. And sometimes they tell us, oh, the customer didn't ask about the new technology. The customer will never know about the new technology. It is our role as eye care professional to always know about the new technology, and secondly, to offer it to our customers. So there is a big need to offer new technology, because 50% of our customers, they need a new experience. They are suffering with their current contact lenses. So old technology would never be a solution for today's issues. Imagine you have a mobile store and you are selling digital devices or mobile. Will you be selling such mobiles? Definitely not. Everybody has been upgraded to smartphones. But in the contact lenses industry, we are 50% or more in the daily disposable and in the reusable market, talking about soft contact lenses, people or consumers, they are still using contact lenses 15 years old or 20 years old with the hydrogel material or old silicon hydrogel material. So it is time. There is a lot of new technologies from different companies in the market, and we need to know about this technology, but the most importantly, we need to offer it to our customers. And the big problem in today's world with the contact lenses is the amount of friction that, because now customers, they are using contact lenses around the day, from early morning till late at night. And they are blinking in this during 14,000 times during the day. So there is a lot of friction between the eyelids, the cornea, and the contact lenses from the front surface and the back surface. And we need to make sure that these contact lenses are soft and lubricant, so with the high softness and with the high lubricity, so the friction is less and the sensation of contact lenses is less. So if we go to traditional silicone hydrogel that it's available in the market and the majority of our customer is fitted with, we see that they are great in oxygen transmissibility. So the problem of redness is being sorted out. The problem of redness, it's done. We did a great job. But the problem with this traditional silicone hydrogel is they have the same amount of water and silicone from the core of the contact lenses into the surface. So imagine at the surface of the contact lenses, we are blinking 14,000 times and we are touching the amount of silicone. So the problem, especially at the end of the day, after 8 hours of wearing the contact lenses, after 9 hours of wearing the contact lenses, there is a lot of friction because of the silicone. And our customers, they are having discomfort, they are having dryness, they need eye drops. And if we continue offering this traditional silicone hydrogel, the customers will not have a good experience. They will not be happy using contact lenses, and they will drop out. So what do we need to use? We need to start using new technologies that they are available in the market. Now there is a lot of new technologies, and one of them is the water surface lenses. Now there is a new technologies in the market that the contact lenses, yes, it is made of silicone hydrogel, but only at the core. The more we approach the surface, the more water. And the more water, that means higher the softness and higher the lubricity. And in some contact lenses in the market, the water at the surface where it's touching the eyelids for 14,000 times per day, and on the back surface where it sits on the cornea, the amount of water is approaching 100%. So nothing is touching the eye. And this is where the comfort and this is where the good experience, especially now that our customers is sitting for a long periods on digital devices, and we cannot offering them technologies that has been produced or developed 15 or 20 years back. So we need to offer them new technologies, because the new technologies will be solving today's problem, like the digital devices, a lot of air condition everywhere in the office, at home, everywhere in the car. So all of this will dry out your eyes, and you need to offer new technology to keep giving your customers a great sensation and a great experience. So the final thoughts for this presentation, please, first, it is our job, and this is a great opportunity. So it's good for everybody. We need to start generating more fits. And we need to understand that our customers, they always rely on us. They count on us to start the conversation about contact lenses. Because when we start this conversation, they will be more on ease, they will listen, and we will give them a better life, and we will be growing our business with them. Also, we need to retain our existing contact lens wearers. We cannot let these customers drop out. We cannot let them go away just because they are still using old technologies. So we need to exploit on the innovation to upgrade our customers. We need to see what's new in the market. We need to understand the new technology, and also we need to offer this new technology. And by driving this category, we will be expanding our portfolio. We will be selling more eyeglasses, more contact lenses, and more sunglasses, and everybody is winning. So, and the best practice is when your customers are happy and your business is happy, and we count on you, because without you as eye care professional, nobody will succeed, neither the practice, neither the consumer. And with that, thank you so much. And it's always a pleasure to be with you. And I wish you the best for the remaining of the webinar. Thank you so much.
Thank you, Mr. Tanios Gajas, for the wonderful talk. Now I am in Bangladesh studio. Now I would like to call our next speaker, Mr. Muhammad Sajjad Hussain from the Riverland, Bangladesh. He is going to talk to us about how to manage a patient with keratoglobus with scleral contact lenses. Over to you, Mr. Muhammad Sajjad Hussain.
Thank you. Happy World Optometry Day. Thank you, team Optometry. Am I audible?
Yes, please carry on.
Okay. Happy World Optometry Day. Thank you, Team United Optometry Forum, for organizing such a wonderful webinar. I will definitely remain grateful to you for inviting me as a speaker. Hi, everyone. There is no financial disclosure relevant to this topic which I will be presenting today. The patient which came to my clinic was very challenging on the time when the patient came to my clinic. It was 2019, February 22nd to be more exact. The patient, Mr. A.A., was around 22-year-old male from Manikganj district on the time when he came to my clinic. He came to my clinic with the complaint of gradually decreasing vision, more for distance and a little bit for near for the last 12 years. Along with blurring of vision, Mr. A.A. also complains of bilateral itching affecting both eyes equally, especially reported to us. When we discussed with the patient more elaborately, furthermore, Mr. A, the patient, furthermore told me that as per previous physician statement, he is suffering by keratoconus, and for that he is using the spectacle for the last 9 to 10 years, but the corrected vision was not up to expectation with the spectacle for the last 5 to 6 years. In this time, he went to several hospitals and so lenses from several contact lens specialists, but the comfortness with this lenses was not up to expectation over the 5 years. And around 5 years ago, he did collagen cross linking in both eyes, and as well as he did deep anterior keratoplasty in his right eye around 2 years ago. And especially he reported to us that the vision after DLK was poorer than before DLK. Currently, Mr. AA is using rose-2 contact lens and is experiencing discomfort, redness, and foreign body sensation with it. Along with, he is suffering by severe photophobia and little pain around eyes when directly exposed to sunlight. Then we discussed with Mr. A and we got that there is no significant medical history as well as no significant family history of keratoconus. And patient told me that previously he suffered by rheumatic fever and joint pain around 12 years ago. For that, taken paracetamol penicillin for the 2 years for unknown dosage. Other than this, he did not told us that there is no significant history of regarding systemic illness or any other disease, and the patient is non-vegetarian, non-smoker, non-drinker. When I discussed with the patient more elaborately regarding his problem. Then the patient told us that he is suffering this problem around 5, 6 years most often between this time. And in this time, he could not do his job more comfortably, and more to be more exact, last 3 months he could not able to continue his job because of his very poor vision. As he mentioned to us that he is previously worked as a government service inspection assistant, and now they to identify the fabric, cloth fabric, become very difficult for him. That's why he currently is unable to continue his job. Then we did a clinical examination, and on clinical examination with this curriculum, we finding that the patient cornea is not like a true catapona, and instead uh, true catapona, the patient cornea is like little bit a globular shape, and there is no significant motion sign. And with the former pentacam evaluation report, it confirmed that the patient is not suffering by catapona, and the patient is suffering by catapona because pentacam evaluation report mentioned us that the patient's cornea is more thinning at the periphery area than its center. Then we record visual acuity, and the visual acuity was around counting fingers 2 feet in his right eye, which he did defective level of cataplasty around 2 years ago. And in left eye, the visual acuity was counting fingers 3 feet. Then we did objective diffraction, and objective diffraction without microscope was dull reflex both eyes, and it can little bit go in around plus 5 or 6 diopter in right eye or minus 20-22 diopter spherical in left eye. Then we did subjective refraction, and with plus 6 diopter spherical subjective refraction, the patient visual acuity improved to around 5 feet, and with minus 20 diopter spherical, the patient visual acuity improved to around 6 feet only. And definitely the correcting vision was not up to expectation with the patient. Then we
Mr.
discussed.
Sajjan, can you please little louder, please?
Okay. Sorry.
Yeah.
Okay. Then we discussed with the patient regarding available treatment options about his eyes, and the patient, when I discussed with the patient, we told him that there is two alternate options. One is clear lens for the right eye, and another one is truck procedure, full cataplasty in his right eye also. But in his left eye, only a clear lens we can advise to you. So after considering all the previous discomfort with RTP, Roche, and other problems, Mr. AA decided to go for external lenses. Decided to go for TAC procedures as the previous history for vision with TLK. Then we trialed Mr. AA with several types of trial lens, and with the when we trial with the several types of trial lens, we faced lots of difficulties during our trial. And when we trial with the trial lens, initially we trial 19 millimeter 3.2 cent and standard lens, and the fitting parameter regarding all was excellent in his right eye, but the corrected vision was around 680. Whenever it comes to left eye, when we trial with the same parameter, 19 diameter lens, 3.2 standard lens, 3.2 standard lens, then patient there is some transitional area zone for the and remaining are excellent. But considering the transitional zone task, we change the lens and we shift to steep style lens. Then we trial, and by this steep style lens, the patient's cornea, there is the same thing, the same transitional area is in corneal task, but in landing zone there is some compression also. Then we shift the lens to flat lens. In the flat lens, same parameter, 19 diameter, 3.2 set flat square lens. With this lens, there is transitional zone corneal task still remain, but compression, there is no compression. But whenever it comes to fluid management, so within just 2-3 minutes, the fluid is dropping from the lens, and the patient reported to us that he needs to blink frequently to see clear image, and the foggy fluid dropping area becomes foggy. So we considered that the flat lens dropping management will be difficult. After discussing with the lab regarding all the barriers, the lab instructed us to to increase the set. Then we ordered the lens, 19 millimeter diameter lens with 3.6, increases set from 3.2 3.6, and the radius also increases from 8 to 8.6. And our final order was for right eye SS in R90 2E1 with +4, and the corrected vision with this lenses was 618, and in left eye BSS in L90 2E1 with -3 diopter, the corrected vision was 6.9, and the patient want to discuss more with the patient what he want to take from this available option. Considering the best vision in left eye and his limited budget, he told us that he is interested to go for a square lens in his left eye only. Then we advise the patient single vision spectacle over the contact lens for constant use.
Sorry, Mr. Sajjad, you just have 1 more minute to finish your talk.
And square lenses for our left eye, and we instruct the patient to come in our follow-up with 3 months. Thank you for your attention.
Thank you, Mr. Mohammed Sajjad, for that wonderful share. And now I would like to call upon Ms. Savita for the last start of this session. And she is from India, a country known for its historical places and ancient monuments. Ms. Savita will take us through how to incorporate Ortho-K into your practice. Over to you, Ms. Savita.
Am I audible?
Yes, you are. Yeah.
Yes.
Yes, you are.
So I feel very much humbled and privileged to share the dais with the eminent speakers. And I wish my whole optometry fraternity a very happy World Optometry Day. And without much further ado, we'll jump into the topic. Today, I'm here to tell about how to incorporate Ortho-K in your practice. So why to incorporate Ortho-K in the practice? So it can be for myopia control, it can be for refractive error, and it is a niche segment. And patient loyalty will be more when compared to an optical store when it is a specialty practice. Also, revenue is very important, right? So Ortho-K will satisfy everything. So what is required to start an Ortho-K practice? Knowledge, instruments, and patience. That's it. You can straight away start your Ortho-K practice. So you can attend, conferences, webinars to get knowledge. And there are many online courses. Most of the online courses are by manufacturers. So they will be more happy to help you getting the knowledge regarding the guidelines to fit their Ortho-K lenses. And you can start one of these courses and then, slowly get more towards Ortho-K practice. So instruments, yes, retinoscope or an autorefractometer to measure the refractive error, and trial sets, slit lamp, HVID ruler, and topographer. So these are the instruments you require to fit an Ortho-K lens. Apart from the trial set and the topographer, all other instruments will be owned by any optometrist in their practice. So if you can afford for a topographer, it is fine. If at all not, then tie up with any practice who where they already have the topography in their practice, and then it's easy for you to do a joint practice. So coming to the test to be done, it can be classified into pre-fitting, fitting, and post-fitting. So pre-fitting test, history and refraction as usual, slit lamp examination, tremors, PBUT, and HVID, most importantly, the pupil size. Here, I wanted to stress about HVID and pupil size because Ortho-K has to cover 90%, 95% of the cornea. So that is very important. So HVID is very important. And pupil size, of course, because if it is for a refractive error correction, the patient might be an active patient. So driving should not be a problem. So mesopic illumination should be considered. And if it is for myopia control, again, the child may undergo a combination therapy. So measuring the pupil size would avoid unnecessary exchanges. So topography maps, pre-fitting topographical maps are done to screen for pathological cornea, to establish a baseline corneal relationship, predict the outcome of the fitting based on the corneal eccentricity and apical radius of the cornea. We will be talking about it in the later slides. And most of the manufacturers ask for, 0.5 diopter steps topography report. And that will be ideal for us to choose an optimum lens parameters or for them to make any customization if it is required. So coming to the E value. Corneal eccentricity refers to the rate of flattening of cornea from the center of the cornea to the periphery of the cornea. So what do I mean by that? Here, if you see the central corneal curvature is about 42.75 diopters. For the same corneal curvature, we can have different E values. It can be 4.4, it can be 0.5, it can be 0.6. That defines the rate of flattening of cornea from center to the periphery. So more the cornea, more the E value towards the 0, it means that the cornea becomes more spherical and you require a customized ortho-K lens to fit the particular cornea. And with this, you have to choose an ideal ortho-K according to the patient. So now you have to consider the active lifestyle. You have to consider the motivation of the parent as well as the child. Age, of course, matters. We can fit ortho-K as young as 6 years old. But whether that myopic child requires ortho-K, where that myopic child is, suited for an ortho-K lens, that is a question. For example, in case of allergic conjunctivitis, we cannot fit an ortho-K. So involvement of parents, because we are talking about children, most of the ortho-K are fit for myopia control. So involvement of parent is very much essential. The parent should assist the children to wear the lens, to remove the lens, to give motivation if required. So all this cleaning and hygiene, everything matters. So involvement of parent also should be considered while you choose the ideal candidate. So coming to the power range, the ideal levels of myopia to begin with, when you start beginning to fit a ortho-K lens, it should be from 0.5 to 4.5 diopters. Spherical designs can correct up to minus 1.5 corneal astigmatism. Greater than that can be fit, but you may require a toric design. And spherical ortho-K lenses will fit more effectively with the rule astigmatism than against the rule astigmatism. So you have to ensure if there is any lenticular astigmatism, and that has to be discussed before in hand, because lenticular astigmatism will not be corrected by ortho-K lenses. So now in topography report, we know that corneal astigmatism should be seen. That should be ideal is to begin with minus 1.5 diopters, and corneal eccentricity, it should be from 0.45 to 5, and apical corneal power, more steeper the cornea, so it possesses the ability to get flattened. So what do I mean by this? So can a keratoconic cornea be fit with the ortho-K lenses? We'll see in the next slide. So in the topography parameters itself, you have to consider about the astigmatism. See whether it is central astigmatism or it is extending from limbus to limbus. So central astigmatism can be well fit with the spherical ortho-K design itself. But when the astigmatism is extending from limbus to limbus, it's difficult. So it is not the typical bullseye pattern we expect, right? So you have to go for a custom-made design. So coming back to the cornea, so steep corneas are very much easier to bring in the necessary flattening effect. So does that mean that we can fit? No. So ortho-K is believed to exert undue stress on a potentially ectatic cornea. So ortho-K is a relative contraindication. We don't have much evidence to support whether to fit or refrain. So better to refrain. So now you have acquired the knowledge. You have taken the topography maps. You have taken all the necessary tests. You have all the readings. Now, how to start fitting? So here, fitting can be done in 3 methods. One is trial lens method, empirical method, and other is the custom-made lens design method. So in trial lens method, you buy the trial set from the manufacturer And by the guidelines of the manufacturer, you choose the initial trial lens, and then you insert the trial lens into the patient's eyes and look for the pattern. For example, if you see here, it is not the typical pattern we expect, right? And you go, might be you have to steepen it or flatten it according to the pattern you see in the slit lamp, and then you modify the fitting, and you arrive at the final lens. So empirical method, you take all the readings, you take the topography report, you take the HVID measurement, you take every other measurements which are required, and then you supply these measurements to the manufacturer. And the manufacturer will be sending you the lenses, and that lenses will be worn by the patient, and you will see for the fitting. If anything required, you will reorder the lenses. So custom made design, you will be designing the back optic zone design, radius, you will be designing the reverse curve, you will be designing the alignment zone, you will be designing the total diameter. So everything will be designed in the software, and that is shared with the manufacturer, and the manufacturer supplies the lenses back to you. So these are the modalities we fit the ortho-K lenses, and whatever is applicable in your country, you can go for that. So post-fitting, you have to check for vision, you have to check for corneal health and topography. And follow-up is very important because it is a night-wearing lens modality. So first day, immediately after removing the lens, check for the corneal health. 1 week, 2 week, 1 month, 3 month, 6 month follow-up should be done. And in every follow-up, ask for the cleaning regime, insist on the cleaning regime, and see whether the lens case is clean. Everything should be insisted again and again, so that we avoid the chance of infection. And difference map. So these are the maps we look for when it comes to the change in the corneal shape after fitting the lenses. So whether it is a frowny face, whether it is a smiley face, whether the lens is central, what sort of difference is there from the previous corneal shape. So that is seen in the difference map. So that has to be taken. So now you have the knowledge, you know how to fit, you know how to troubleshoot, and now where will you get the patients? So that is more trickier, right? So you have to start talking about ortho-K as an option for myopia control, for refractive error correction to anybody who walks into your clinic. Tell them that there is something called ortho-K. It's a magic lens. The vision will be corrected without spectacle lenses, without contact lenses. So in the morning, without any aid, they can see clearly. Might be, if you talk to the parent might have a child who's a myope, and that parent will be motivated to go for an ortho-K lens. Your fellow optometrist and ophthalmologist would be a good referral source if they are not practicing orthokeratology. Your old patients will refer more patients to you. And of course, social media. Nowadays, nothing happens without social media. So be alive in social media. So this is a recent case I have reviewed after 2 years of fitting an ortho-K lens. He was 7-year-old when I had fit him with ortho-K lens, and he has progressed by 1 diopter that time. And his refraction was around minus 4.5 with minus 0.5 at 180 both eyes. And till now, it remains the same. There is no progression at all. It's a beautiful technology. And this is the topography report, which was taken 2 weeks back. And here I just wanted to share the review.
Hi, Adrit. Hi, am I audible to you? Hi.
Yes.
Yes. Adrit, can you share your ortho-K experience? Like for the past 2 years, you're wearing ortho-K lenses. Before that, you are wearing spectacles. So how you feel about ortho-K lenses and what is the difference it has made to you? Can you share it with us?
I like orthokeratology lens because it holds your sight and does not change the sight at all after you wear them. Yes, and it feels very comfortable while wearing it. And then in the morning, I can easily play anything. It removed my glasses and makes me able to see properly without any glasses, and holds up my sight without changing anything, and even decreased it little.
Give it to your parents so that they can share the review about the ortho-K lens technology.
Yeah, doctor.
Yes, sir. Hi, sir. How are you doing?
Hi. Yeah, doing well.
Yeah. So I thought of taking review about ortho-K technology because you have adapted the technology even 2 years back itself. It was very new to India. We started just 4 years back in India, and you adopted it very soon. Did you had any fear of making your son wear orthocare lenses, or like how did you see all this journey of transforming him from spectacle lens to orthocare lens, and what is the
Yeah,
pros you and cons, if at all you want to share anything, you feel feel free to share with us.
far as here our concern is concerned, absolutely there is no stage because it is very comfortable because he is wearing it in the night. That is the advantage because in daytime he could play anything. He expects wearing will be risky for the kids while playing something with physical games. So what he is playing, it was now it is suits for him. And more than that, there is no increase in the sight. Increase, it is stable, and he is very comfortable with the wearing in the night and removal of that lenses in
So
the
from parent point of view, did you face any difficulty in wearing the lenses?
Yeah, hi Savita.
only
You're in
thing
the
is
last
that in
minute.
the
Yeah.
night, the advantage is
Yes,
that
there
my
will
kid
be
never
one more slide.
rubs his eyes with the hands. That is the only area where someone should be careful. Other than that, there is no problem.
Okay, so you're happy with the lenses?
Very happy.
Very happy. Thank you. Thanks for the review. And would you be recommending orthocare technology to control power and to have a spectacle-free vision to anybody who's having minus power, myopia?
Definitely, because it has so many advantages. And there is no risk factor. See, the concern will be the risk factor, whether there will be a decrease or increase, there is a damage to the eye. So these are the concern. When there is no absolutely is fine, then I don't feel anything.
So this is the review the patient has given. To wrap up, to start an orthocare practice, you need to develop necessary skills. Yes, because we are dealing with cornea. And you need the instruments. The most expensive one is topographer. We can buy if you got affordable. If not, tie up. That's it. So choose an ideal candidate. Don't jump for -8, -10 to begin with. Always stick to under -5 when you are a beginner, and then let's begin the journey of fitting orthocare practice. Because we expect more myopes, right? Like the whole world is turning into myopia, and we optometrists have definite roles and responsibility in controlling myopia. So with this, I thank EOF for the opportunity, and I wish them more EyeQon seasons in the future years. All the best.
Okay. Thank you, Ms. Savita, for that wonderful share. And please stay back for the panel discussion. I would also request Mr. Sridhar, Mr. Mohammad Sajjad, and Mr. Tanyus to join the panel, please. And I'm happy to invite Mr. Zach, optometrist, deputy lead at Moofels Eye Hospital, UAE,
Zach.
to chair the panel, please. Over to you, Zach.
Hi.
You're
Zach.
muted, Zach. Yeah.
Got it. Thank you for the introduction, Canny. Excellent presentations, everyone. It was really nice to see the videos of patients this year, both in Sridhar and Savita's ones, where we can actually see a glimpse into the clinic, instead of the static images that we're used to. So that was nice. And great work to the team for the transitions. They just get better every year. So I'm already looking forward to next year. I've got a few questions. The first one is Ob there? No, he's gone already.
No, Ob is not here.
No problem. Well, we'll just go on then to Sridhar. One question I wanted to ask. Now, you were saying that you normally use the soft silicon hydrogel, and some of your patients were quite young that you were showing. How often do you ask the parents to clean the lenses? Because I know this can be a little bit different depending on, different optometrists. How often do you ask them to remove and clean it?
How often do I ask them to clean the lenses? It's on daily basis after every use.
Yeah. We because I've heard of some practitioners, and if the children are very young, 0 to 6 months, sometimes they say once per week.
No.
You try and do it every night if possible.
No way. It's every night. The lens has to be cleaned, and I always stress on this point.
Yeah.
And I always ask open questions, when the parents, or forget about the parents, even any patient that walks into my clinic, I ask them, very open question. Just ask them, how often do you clean your lenses? And you'll get the perfect answer. Yeah, whenever I remember, or once in 4 days. Once in 2 days.
There's always that quote where, people treat their children or their pets better than they do themselves. So, maybe if you tell them every night, maybe you're more likely to actually get them to do it instead of the adults who have lost a bit of interest. Thank you for that, Sridhar. Mr. Tanios, it was really good that you highlighted, the value of the contact lens patients. I thought that was really interesting, 3 times more valuable, because quite often, these patients that come in for just a refraction or a glasses check, they leave quite often without actually realizing the value that a contact lens can bring. I just wanted to ask, I think you're based in Lebanon, isn't that correct?
Yes. I'm in.
Oh, still here? Oh, he's gone.
Yeah, he's gone.
Well, I can come back if he reappears.
Yeah, he's there now.
Yeah,
Okay.
I am based in our offices in Lebanon, and I cover the whole Middle East.
Well, I was just looking that you said it was 10% of customers wear contact lenses, and I seen that it was in France, Germany, and Australia was where that data was taken. Do you think it would be higher or lower in Dubai and the Middle East than 10%?
Yeah, we did in our company, we did an internal survey with our top customers in the big cities.
Okay.
And without going to the remote areas, and in the big cities in the Middle East, like Dubai, Abu Dhabi, Riyadh, Jeddah, it was around 8% only. But if you go to the remote areas, the faraway areas from the big cities, it's getting lower than 5% in the Middle East.
Oh, wow.
So,
Okay.
so yes, we have but it's always an opportunity for all of us, for the patient and for the practices, for sure.
Yeah, I know that obviously refractive surgery is pretty popular. Most of the staff here are sort of UAE, Middle East based. And maybe that's worth having a conversation of. Maybe we should be fitting younger patients with contact lenses, getting them glasses free, and then hopefully they'll not maybe opt for the surgery.
Totally agree with you, Mr. Zach, because starting with younger people, because now the eye care professional, they are always waiting for the patient to become 17 years old or 18 years to offer them contact lenses. But we all see that when you start with the younger generation, and if there is only 2 things, is the maturity of the patient, whether he's 11 years old, 12 years old, or 13 years old. If he's mature, with the agreement of his parent, and always start with daily disposable contact lenses, the age is not a problem. So we should not wait. I totally agree. We should not wait until older age. We can start with the young population, and it's enhancing their life because they are always active and they want more than from life.
I think what's quite nice is, the way you're sort of highlighting about asking the question. And without taking much note in my own practice, I always ask in history and symptoms, if I see a girl 15, -2, -3, oh, do you wear contact lenses at the start? And it puts the parent and the patient in, oh, no, I don't wear contact lenses, but maybe that's a good thing. And it means at the end of the consultation, you can follow up on that. But just asking someone, do you wear contact lenses? Ask the question, maybe I'm eligible, which is great. Mr. Mohammed Shahzad, yeah. Excellent case with the keratoglobus globus. I just wanted to ask, was the reason why you opted for a 19mm scleral lens because of the keratoglobus? Was that one of the factors that made you go for a slightly larger diameter than I'm sure most of us would probably opt for in a traditional keratoconus patient?
Yeah, actually we started with 16, then 16.5, then 17, then 17.5, 18, then 18.5, 18.5, 18 and 18.5, and on that the lenses there is a significant corneal curve, especially in transitional area, intermediate area. That's why we went choose for 19mm. Even with this lenses also there is a corneal curve in transitional area, but the Percentage corneal task is comparatively less with 19 mm. That's why we discuss here only for 19 mm, and remaining other lenses which we trial in our clinic is skip. But we trial.
You know, it was an excellent case, and thank you for that. It was nice actually that they had a graft in one eye and sort of, you know, I think it was just cross-linking in the other. So you had basically two patient examples in one, which was nice. And then just finally, Miss Savitha, I thought it was an excellent point about the pupil size and myopia control. So I know that the time's almost up. But it was quite a nice point just to highlight, you know, if these people are driving, because usually we think ortho-K children, but it was quite nice to bring that home. Just
Now we have presbyopic ortho-K also.
You're fitting them as well. You're braver than most practitioners out there, toying with the presbyopia and ortho-K. But I did want to ask, if someone comes to you from either another practice, town, country, and they have lost their lenses, or they have some lenses but they don't know the parameters, what do you have as a washout period? So between removing the lenses and let's take let's call it a normal scan or an untreated eye scan, what's your normal washout period?
The evidence says 30 days. The evidence says 30 days we have to, wash out and then refit. But I have seen when I had a patient who had been fit with ill-fitting ortho-K. The patient was taking topography. It was like a keratoconus suspect. Okay. So what we had done, we had actually discontinued the lenses for 1 month. Even still, it showed keratoconus suspect. So after 6 months of time, when we took the topography again, it was a normal cornea. So we had refit the lens, and the patient is now wearing the lens for the 3rd year successfully. It is a perfect bullseye pattern. So it's like, depends upon patients to patients. So ortho-K is like still evolving, right? So condition matters.
So at least 30 days, I think, is the minimum that we should go for. Great.
This 6 months, it took 6 months for the cornea to regain its shape is something.
No, we didn't take in 3 months again. Like we had taken, because it was for myopia, we switched the patient to soft myopia control lenses. So after 6 months, once the lens, stock is over, we took again and it was like normal. And then we had fit her with the ortho-K lenses again.
Oh, nice.
Perfect. Thanks, everyone. I think we're just on time, maybe a little bit over.
Okay. Thank you. For the sake of time, I think we need to close this session. Thank you all very much. Thank you for sharing this one. And thank you, speakers, to one and all for the wonderful session.
Okay.
Thanks, organizers. Thanks, Kani ma'am.
Thank you. Thank you very much. And please stay tuned for an exciting quiz session at the end of the, session. And also keep watch on our chat where you'll get the registration link for Optoverse 5 optometry conference, which will be an on-site one held on 11th and 12th of October. So moving on to the next session, please. Please get tuned for the same.
Welcome all. I am Shahida Shamsuddin from Sheikh Khalifa Medical City, also one of the core committee member of UAF. Now, let's unlock the panoramic view of reality where objects come live with depth and dimensions. Let's move on to Mr. Swarna Kamal from our UAE studio.
Thank you, Ms. Shahida. Let's start today's second session of the evening, Binocular Harmony under the tallest building of the world, Burj Khalifa. We have lovely speaker, Dr. Rizwana Husainuddin from UAE, and she'll be speaking on how to integrate binocular vision into your primary eye care practice. Over to you, ma'am.
Hear me as well. Okay. So first of all, wishing the entire optometry community a very, very happy World Optometry Day, and acknowledgements to the team EyeQon and the UAE Optometry Federation team for giving me an opportunity to be speaking with all of you on integrating binocular vision in primary eye care. I am not going to speak really complicated subject. This is not a complicated, the topic looks complicated, but I'm not going to like talk about complicated procedures, because I was listening to the previous session where the speakers shared their expertise on contact lenses. But, when it comes to binocular vision, we all know that we handle people with frontally placed eyes, and we have two eyes, but we still see one. Unlike the cyclops that we see here, where there is nothing to worry about binocular vision. Also the octopus, where the individual visual processing is going to be done separately. And there is no role for the visual cortex or the areas of binocular vision in the center to then integrate and harmonize the images between both the eyes. And this is a favorite quote that I almost end up saying in all of my presentations. So when we talk about all of the sophisticated techniques and tools that can simplify various aspects of our life in optometry procedures, we know when it comes to refraction, there are machines that can refract. Even AI and machine learning will one day replace that. So at the click of a button, we're going to like get a prescription, I think, which is almost there with some of the advanced tools. But after you prescribe glasses, and then when the patient is unhappy or when they have any sort of eye strain, they wouldn't want to sit and talk with the machine, and definitely they're going to come back to you. And this is more obvious when patients have binocular vision dysfunctions or anything to do with the coordination between the two eyes. Now, why are we talking about binocular vision at all? So because when there's this myopia, booming prevalence of myopia all across the globe, but do we really know the statistics of binocular vision? In fact, this is not even the updated statistics. If you look at statistics that came from around the globe, let's say 20 years back, like almost 2 decades back, versus the data that came right before COVID, it's a double-fold increase in the numbers. And then this is the paper that if any of you want to go and read in detail, where this is a paper from Southern India that's part of my doctoral research. So what surprised me at that point of time was this was much, much higher than even refractive errors and continues to be. But yes, the symptomatology of the children are very important. Like how many children really then report eye strain or report reading related visual issues. And so when we looked into it, we found that the prevalence of convergence insufficiency is almost 16% and accommodative infacility was 10.8%. To simplify these numbers to the practicing optometrists who are listening out there, if you're going to be seeing, let's say, 10 patients, okay, almost 3 of them are going to have a non-strabismic binocular vision dysfunction. So out of every 100 patient, you will have binocular vision dysfunction in almost about 30 people. And so what are we really missing? And of course, COVID has become a story now, but then the impact or the influence of COVID on lifestyle still remains, and it's not going to go back to baseline. So when we look at the influence of COVID on convergence insufficiency as such, which is just one part of the entire spectrum of binocular vision dysfunction, what was surprising is this paper that you see here from Spain, where almost there was 100% increase in convergence insufficiency, which means people who never had a convergence insufficiency before the isolation period, who ended up using gadgets where there was almost a 200 hours increase in the screen time, the prevalence of convergence insufficiency and symptoms was almost 100%. So definitely the influence of lifestyle has a lot of impact on binocular vision. And where do I start? That is the question all of us ask, right? Where do I really start? Yes, all of us are trained to do comprehensive assessment of the eye and visual system and then to prescribe appropriate refractive testing and correction. It definitely starts there. But then immediately, I would say, to be able to provide appropriate refractive testing and correction, which also improves the visual efficiency, which provides single and comfortable binocular vision, it's really, really important to ensure that the basic binocular vision parameters are good enough. Okay. So, of course, people who are watching us out there can put on the chat box with respect to what binocular vision tests are generally performed by the optometrist as a routine. What do you really think? Okay, so if you say near point of convergence, accommodation, facility, foria, vergence, amplitudes, whatever you think, you could just go ahead and put it in the chat box, or you can write it down for yourself. This is more for us to reflect on the current level of practice that we have with respect to binocular vision. And what is your practice pattern looking like? How many of us ensure that you include BV as part of your comprehensive eye examination? When I say binocular vision, I'm really not talking about the 1 hour protocol or the entire test battery. But for you, when the word binocular vision is spelled, what is coming to your mind is what I would like to understand. So with that, I'm going to just present two simple cases that most of us would definitely see day in and day out, and then give you a perspective on how binocular vision comes into the picture, especially when it comes to managing simple refractive errors. So this was a 34-year-old female who came to me with complaints of asthenopia, and she had a lot of blur, and she said that she couldn't comfortably watch the screen on the cell phone, and also she had eye strain reading newspaper. As you see, 34, still not presbyopic. Visual acuity was perfect for distance. Near visual acuity, she still had N6, but she was reading with lot of effort. And the retinoscopy did not show much of hyperopia. And as usual, we have seen these patients, right? They don't take any plus. And we also, as optometrists, be it in the retail practice or hospital practice, we don't want to complicate things by prescribing a plus lens. So we are like, okay, can I then do anti-fatigue? Can I then prescribe near addition? Oh no, not presbyopic yet. So what do I do? Now, should I refer her for cycloplegic refraction? The question you need to ask is that, okay, she's not even accepting the values that you've got on retinoscopy. What is the purpose of referring for cycloplegic? Is it just to find or unravel the total amount of latent hyperopia? Can we then handle it in a little bit more comprehensive optometry way? Yeah, that's the question we need to ask. So I would like to definitely ask you, what would you do, right? So keep thinking about what you would do in such a patient, while I'm going to present the BV procedures to support management because I don't have much time. So Borish delay testing. We have heard about it in the optometry school. Some of us practiced it, and then many of us then stopped following it. But yes, people who are in the binocular vision department definitely, I think, might do it day in and day out. So what is Borish delayed is, first, after you perform your subjective refraction, you do your normal refraction first, your monocular subjective acceptance, after which you do negative relative accommodation. So what do you do in negative relative accommodation? You add plus lenses in 0.25 diopter steps binocularly while the patient is viewing a reading material, and preferably you give a target that the patient is comfortably able to view. And then you keep adding plus lenses binocularly until the reading visual acuity becomes blurred. Now, after which you redirect the subject's attention to a distance target, which is the visual acuity chart, and assume that the normal values for NRA is usually between plus 1.75 to plus 2.5. And then, so there's a lot of plus, almost much higher than the usual fogging lens that you would have. But in this patient, we had plus 2.5. So when you redirect the subject's attention to a distance visual acuity chart, the logic would dictate that they may not be even able to see 6 by 60 clearly. So then you start defogging them binocularly in 0.25 diopter steps until they are able to read 20/20 or 6/6 comfortably. Okay. The end point when you do a Borish delayed is not to push plus to a point where they read 6/6 with effort, neither to ensure that you quickly defog and then so that they land up with a plano, but you take time and give time for the accommodative system to accept, to relax and accept, to relax and accept. And then you leave them with an endpoint where binocular vision is single, comfortable, and clear. And then you show them the near visual acuity target after you finish this. And in this patient, while we did the procedure, she accepted plus 0.75 comfortably. Now, what did the Borish delayed, the magic that Borish delayed do, which you could not achieve in monocular acceptance, is that first, when with both eyes open, you've added plus lenses, the maximum amount of plus lenses that's required to relax accommodation at near. So you've relaxed the accommodation to the maximum, which was not possible when you were doing monocular acceptance. And then now you know, like, okay, this is the maximum that this patient needs for near. And then with that, because you've started defogging for distance binocularly, you definitely are able to push a little bit more plus. Plus, day in and day out, nobody is looking at monocular visual acuity. Yes, there are some of the sensitive patients. They would say, oh, you know what, like my one eye acuity is much more clearer and all of these things, where you can, of course, bring in the concept of dominant eye. But then the purpose of pushing plus in latent hyperopia, in overcorrected myopia, in early presbyopia, in pre-presbyopia is to ensure that they have comfortable binocular vision at both distance and near. Now, logic might say this patient might end up using glasses only for near, but that doesn't matter. Now, the instruction would be, okay, because you have blurred near vision, you have asthenopic symptoms at near, these glasses are required. You can start to increase the wearing time slowly over a period of few weeks. And it would be nice if you're able to wear the glasses almost all the time, so that you are not straining your accommodation. And later, when she really becomes presbyopic, or if you want to push more plus as she advances into that age, it becomes even more easier for us. Now, in case, like, what are the other procedures that I can use in the place of Borish delayed, because I really don't have 4 minutes. You can definitely do monocular estimate method retinoscopy, where you have these MEM cards that you put on the top of the retinoscope. You ask them to read the letters, keep it clear while the procedure is performed under normal ambient room illumination. You find the amount of plus. If it is more than plus 0.75, you know that they definitely require plus lenses, and then you push plus. If you're using a phoropter, well and good, you can use a fused cross cylinder. You have your duochrome, but you can do a binocular balancing with duochrome. And you can use other procedures like near points and positive relative accommodation to confirm. But I love Borish delayed and monocular estimate method because it usually gives me directly the numbers that I need to prescribe to the patient as spectacles. Okay. The last case, another common scenario that we were seeing earlier, but post-COVID, it just ramped up, and which is the case of overcorrected myopia or accommodative spasm, which starts sort of showing up as accommodative excess. So this was 16-year-old child that started wearing new glasses, and then the child is non-myopic. And I'm not getting into myopia management here. Let me keep that simple. And then the last prescription was -1.5. And then the current prescription that was prescribed by another optometrist was -3. Visual acuity was good with the current prescription, but the patient had asthenopia. So what important BV procedure should immediately come to your mind here should be to check the near foria. Patient had ESO. That tells that with the new glasses, the patient is accommodating more than what is required, or converging more, which means the amount of myopia that is sitting on top is definitely a little bit higher or a lot higher. And even retinoscopy was showing variable refraction. And again, as optometrists in primary care setups in optical units, we would want to refer the patient to the ophthalmologist for cycloplegic. But here you have two numbers. You have a previous number of -1.5. You have your retinoscopy value. So yes, you might want to refer for cycloplegia for two reasons. One, for documentation. Second, to break the accommodative spasm, because doing a cycloplegic refraction not just gives you a value, but also then breaks the accommodative spasm cycle. So what would you do? And as you keep thinking, I'm going to once again go back to my Boris delayed, because this is a procedure that, is so handy that it has helped me handle a lot of patients without actually even putting them through a cycloplegic refraction. Okay. So if you take home something or want to practice something from tomorrow or restart your practice with something that you've stopped doing, then please do Boris delayed. So the NRA was +3.5, and then it really tells you that definitely there is an overcorrection in place. And when we defogged, immediately the patient was able to accept lesser minus. And I'm telling you guys, when you practice, you will realize that without cycloplegic refraction, what magic can be achieved with the help of Boris delayed. But the most important piece in here is the adaptation that needs to be given, which I gave for 30 minutes, explained about the overcorrection, and new prescription was given. And because, in this case, there is exams, I can't do cycloplegia, I can't leave the patient with these glasses. What if they end up with a large ESO? So yes, okay. You can also do binocular balancing, and it's really important that you check refraction when the visual acuity is not reduced with fogging. So assuming that all of us are still doing regular fogging, now look at this autorefractive values here of the same patient that changed from -225 to -625 just in a period of almost 10 minutes. So this patient was coming to us like with constant change and fluctuation and refraction. And of course, she was almost 37 years old. You wouldn't expect an accommodative spasm sort of a presentation in that age, right? But I'm telling you, people can present with pseudomyopia or spasm at any age. And then a lot of other conditions, including mental well-being, emotional issues, anxiety, depression, antidepressant medications, all of these have got a huge effect on the accommodation system. So whenever you do okay, after I do retinoscopy, I put the +1. Yeah, I'm wrapping up. I'm wrapping up here. So with the fogging lens, when you are redirecting the subject's accommodation to distance and you see that they are just able to quickly read, then you should know that there is something apparently wrong. So this is the procedure that I wanted to introduce. If you want to add a minimum battery of binocular vision procedure, of course, please go and read this paper by Dr. Prem Nandini, which talks about a modified version of Boris delayed. Okay. And then so people ask, what are the sort of minimum test battery that I need to then do in my practice? 3 procedures. I'm not going to go into it again for time's sake. You can go and read this paper, euphoria, near points of convergence, and accommodative facility. So these are the 3 procedures that you would definitely, I would suggest that you integrate based on both research evidence as well as based on your you get enough of data, but also minimum data to be then able to find out if they have convergence insufficiency, if they have accommodative infacility, because these two are the most commonly prevalent conditions. And then if you are able to pick it up, then you are almost managing 99% of your patients. So with that, I'm wrapping up my presentation and over to Shaida.
Thank you, Dr. Rizwana.
Now I am in our studio from Singapore, the garden city with iconic skylines and lush green urban parks. From here, we have our next speaker, Dr. Tiong Peng Yap, to talk on oculomotor dysfunction in concussions.
Hello. Hi. Is everything good? Can you hear me?
Yes, we can.
Yes.
Oh, that's great. That's great. Thank you. So let me just get the slides out again. And you can see the slides. Yeah? So nice to be here with all of you to celebrate the World Optometry Week. I'm very privileged to be invited to speak at this conference. You know what? I'm an optometrist in private practice, and I started out doing primary care optometry. And what I find is that I have been doing mainly primary care work. I was doing a lot of comprehensive eye exams, and as a result, I began to see more and more complicated patients. and so binocular vision anomalies tend to be the kind of cases that I usually get the moment everyone started hearing about the work that I do. So one of the things that I am quite passionate about right now is on oculomotor dysfunction in concussion. And today my topic is primarily on fixational disorder. So fixational disorders can occur after concussion, resulting in an inability to maintain a stable image on the fovea. So this is an overview of what I'm going to talk about today. I'm going to talk about the neurological processes involved. I'm going to talk about the anatomical fovea area, which is responsible for fixation. And then I'm going to talk about fixational eye movements, which are normal, and also introduce the concept of retinal image slip. Then we're going to talk about concussion and the post-concussion syndromes. And then I'm going to talk about the cortical areas that are involved and then treatment. But before I start, we should just clarify what fixation is. So fixation refers to the ability to voluntarily maintain a steady and accurate position that is focused on the target in order to prevent the visual perception from fading away. So let's take a look at where we are here, fixation. So some time ago, I drew this diagram as I was writing a book chapter with Katie Stern. And as I was doing this drawing, I put fixation in the middle. And the reason for that is because there are two major neurological elements in the process of fixation, which is vergence and accommodation. And this is why it's so important to have good binocular function. And these two functions are tightly coupled. And if there is difficulty in these areas after a concussion, there may be difficulties in getting the patient to fixate properly. And because fixation drives eye movement, fixation is important in eye movement. So if you're going to do a pursuit or saccadic eye movement, you need to be able to fixate properly. And so there is also the integration with the vestibular system, which is also essential for balancing. So a lot of times when people have a concussion, they may have many symptoms, and some symptoms relates to perception of movement, headaches, visual discomfort, and sometimes it's just so difficult to address some of these concerns. But let's take a look at the fovea. And if you look at the fovea, it is so the fovea field covers only about 2% of the visual field of each eye. So precise fixational eye movement is needed to prevent the visual image from slipping away from the fovea. So if you think about the retinal image moving away from the fovea, so if it's slipping away, that would tend to result in poorer resolution due to the lower density of photoreceptors away from the fovea. And that would also tend to produce unwanted motion as a result due to the movement across the photoreceptors. So, so if you look at this research that is based on a retinal tracking scanning laser ophthalmoscope, so what's interesting here is that these are actually normal fixational eye movements. So when you're fixating, the eyes are actually making some movement, such as tremors, drifts, and microsaccades. And these are important to fine-tune so that the eyes remain fixated. So if you look at the small little oscillations, those are actually the tremors. And then there are drifts that goes, those slow drifts, and they're of pretty small amplitude. And then you get a red, so the red line is a saccade, and that comes, that's a microsaccade that goes back to fixation. So every time you're fixating, the eyes are constantly trying to adjust and readjust the focus. So, but if you take a look at patients who have a concussion, generally, from research, it seems to suggest that there is a significantly larger magnitude of a microsaccade, and there is also significantly higher velocity and acceleration in order to maintain the fixation. So what this is really telling us is that the visual system is having a hard time to deal with the movement and blur from the retinal image slip. And so even though the brain can tolerate small amounts of retinal slip to see the target clearly, the patient must be able to keep the target in focus at all times. And this can prove to be quite difficult in a patient who has concussion. And a lot of times, patients with concussion tends to have trouble in sustaining attention. So if you look at the brain areas involved in eye movement, in convergence, and if you compare that with attention, they are pretty much in very similar areas in the brain. So this is a research from PET scan showing the red areas that lights up due to the increased blood flow. And fixational disorder post-concussion can affect a person's visual attention in a similar way to the poor fixation that's linked to ADHD traits. So that's the reason why it's quite important. And if the fixation is poorly engaged, the patient may find it easily, the patient might be distracted more easily. So that would result in poor attention. And here's another research that is quite interesting. So what they found here is that the microsaccade can even result in a gaze shift from a target to another location of interest. And this might cause them to be distracted more easily, thus affecting visual attention, visual perception, and cognition. And because microsaccades are conjugate eye movements with equal velocity and amplitudes, so the two eyes are supposed to be moving together. And because the accommodation and vergence systems are also tightly coupled in the process of fixation, it's just so important to look at binocular vision when we are looking at people who have concussion. And so looking at the different neurological elements here, such as fixation, vergence, accommodation, these are all areas that can be trained, and of course, pursuit saccades and vestibular system. So if any area of these functions are found to have a deficit, if any of these areas are found to be functioning poorly, these are actually areas that can be trained with vision therapy. And because these issues are functional in nature, the only way to treat a functional problem is to treat it functionally with exercises or activities involving vision therapy. So with that, I complete my talk today. So just to showcase here a study that I'm working on, which is a scoping review on ocular motor dysfunction or disorder in children and adults with mild traumatic brain injuries. So this is something that I've been working on lately. Thank you very much.
Thank you, Dr. Tiong. Now I am here, the oldest country of the Europe, Portugal. And we have a lovely speaker, orthoptist Carla Lanka. She is speaking on prism relocation in patient with central scotoma. Over to you, ma'am.
It's a pleasure to be here to present this presentation on prism location in patients with central scotoma. I would like to thank the invitation and also say that I'm very, very happy to be here to celebrate the World Optometry Day. So as we know, patients with age-related macular degeneration, they can develop central scotomas. AMD is the most common leading cause of low vision among the elderly, especially in developed countries. So they develop this central scotoma, which is an area with absent or poor vision. And this area has, of course, a loss of foveal stable fixation. As other situations where we have a central scotoma, most of these patients will develop a new area of fixation. So as you can see here in this image on your right side, you can see on red the central scotoma. And then here with a black color, you can see another area that we usually call the preferred retinal location. So this will be as a new location to use for fixation. Of course, this new location has not the same value as the fovea, but of course, as fovea fixation is lost, then this area can be better to use for visual activities. So this area can be measured accurately in clinics with a microperimetry, but there are other tests that we can do in clinical practice, and I will show you later on. So in terms of visual rehabilitation, what we can do, I usually do it in two phases. So the first phase, as we can also see in the literature, is to spend some time in training the eccentric view, and this can be done with prisms, and my presentation today will focus on this with the prisms. And after this, when the patient is able to use the new location, then we can think about using magnification and low vision aids. So this is an example of what we can do. We use the prism to do an image relocation. So this method will help to stabilize oculomotor functions, and it has a purpose of promoting a better area, a better PRL. So the prisms are incorporated into the spectacles, and they will redirect the images to this new pseudofovea. So here in the image, you can see a central scotoma, which is covering part of the letters when the patient is reading. And then you can see on the green color, a lateral PRL. So how we can do this in clinical practice to determine where the area is located. So usually you can do this when you are doing your determination of visual acuity. So you have to determine the best corrected visual acuity for distance. While you are doing this, you can understand which eye is the better eye, and also you can locate the PRL. So how to locate the PRL? You have to pay attention to the head position of the patient and also the eye movements during the VA testing. You can use prisms. When you find this location, you fit the base of the prism in the direction of the face turn, or the apex in the direction of the eye turn. So you know that a patient has this location when you can see doing VA that the patient is trying to compensate the movement with the head. They will have head turn or eyes turn. And those behaviors you can observe while you are doing the VA, but you can also ask the patient. So the patient many times will be able to self-report what's happening. So in three phases, what we should do is to ask, benefit, and optimize. So first you ask the patient, you put trial prisms in the trial frame. The prisms can be from 6 diopters to 8. In some cases, you can use even 4 prisms for some patients. And you ask the patient to rotate the prism until the point that the patient will see or will have better vision. So when you find the point, you have to see if there is any benefit in visual acuity, and you determine this benefit by seeing if there is a better visual acuity for the patient, or if there is a decrease in the compensating head movement. And if you decide to move forward, if you see that this is a good location with a better functional vision, then you should train eccentric view. So this will be to optimize the efficient use of the PRL. So you can see a patient here. This is a visual field. You can see the lesion here on the top of the visual field. This is a patient with a myopic maculopathy with 60 years old. The patient had a 20/50 VA when we were doing the visual acuity and had a head posture. So we did a visual field and analyzed the location of the PRL and decided to fit a 4-prism base up. And we have seen that the patient improved the vision and there was no head posture after that. So other ways that we have to measure the PRL, we can use the Amsler grid that you can see here on the left. This is very useful to determine the central scotoma, but also the location of the PRL. There are others that can use the clock. As you can see here, the clock, you can ask the patient to fixate the numbers and go on fixating the numbers until the patient can see the star clear. And then you will have the location of your PRL. And another way of determining the PRL in clinical practice is to use the face fields. So you sit in front of the patient and then you ask the patient to describe your face and then let you know which parts of the face are not visible and which parts of the face are visible. But most important, to determine accurately the PRL, we should use microperimetry. Anyway, because many clinics do not have access to this objective measure, then you may use all other measures to try to help your patients. Patient selection is very important. Not all the patients will benefit from being prescribed or fitted with prisms. So we know that most patients will develop their own PRL, and this is spontaneous and is self-discovered. So if you find a patient that already has a good PRL and is using this PRL and is well adapted, then this is not a good case for fitting prisms. So who are the good cases? So patients that have problems maintaining the abnormal head position, or they have problems maintaining the position of the eyes. It's also important to choose patients with macular lesions, but long-standing macular lesions, which means that the disease is not progressing, not evolving, and it's stable. Because if the disease is progressing, then you will have different PRLs and there will be an unstable situation. And also, according to the literature, it's better to fit prisms in patients with absolute central scotomas, because if there is different density of scotomas, this will influence strongly the fixation behavior. I've did a bit of research to let you know what has been done so far regarding 3-month follow-up, but also, and importantly, there was some slight improvement at 6 and 12 months follow-up. And they also found that you can fit monolateral or instead of bilateral prisms in some of the cases, which is also a viable mean to improve visual function. There is another clinical trial which I want to highlight as well, who didn't find the prisms to be helpful, but it is possible that in these clinical trials, some of the patients were already adapted to their PRL. So that's a thing that we have to take in consideration, because if the patient is adapted, then it's not a prism that will change this habit. So here I show you another case report. This is another patient with a myopic maculopathy. Here on the left, you can see the visual field of the patient. And then here you can see the visual field of the patient where we fit the prisms, 6 diopter prisms with 126 degrees. So we did the visual field with the prism, and as you can see now, the center visual field is much clearer. And we found that this patient, after 3 months of training with the prism, he had a reduced head posture with the prism. The VA increased by 2 lines. And we also found that contrast sensitivity was better with the prism. So take-home messages. So from our previous experience, the prism usually varied between 2 and 6 diopters. It is very important to measure the outcomes. So we need to understand if VA is better, but also other measures are important, such as contrast sensitivity, reading speed, and face recognition. And also it is important to emphasize that we cannot just fit the prism. We need to do some eccentric fixation training, and we can do this at the clinic before we decide to prescribe the prism. Another thing that is really important on those cases is to discuss with the patient. So even if you see that there are better results in terms of your clinical results, it's important to also listen to the patient and to see if there is really a benefit for the patient and for its daily life. I'm just coming to the end of my presentation. But before I finish, I want to acknowledge the work of my colleague Nadia, because it was with her that we started to fit the prism in patients with central scotoma, and she helped me to prepare this presentation for today. Thank you so much, and enjoy the World Optometry Day.
Thank you, Ms. Karla Lanka.
Now, I am in our studio in India, the land of unity in diversity and spicy aromatic cuisines. Here we have our speaker, Mr. Oliullah, to talk on how to manage intermittent strabismus in optometric way. Over to you, Mr. Oliullah.
The best way to celebrate World Optometry Day, thanks to EOF for organizing this session and having me here. Before I start, my thanks to my fellow optometrist, Afan, for helping me in preparing these slides. So previous speaker were excellent in talking about how optometric approach can help to increase our practice, scope of work every day. So today I'm here to talk about another common condition, though we may think it is not common, but let's see how common it is to manage in optometric practice, and it's about intermittent strabismus. As we all know, that it is primarily a sensory motor anomaly where you see the binocular vision is affected and the line of sight are not at point, and it is failing at occasional or probably some point of time when the patient is not active enough to hold the target single. Now, if you look at the severity of it, it is typically depend upon that how the angle of deviation changing from like morning to evening, or whether binocular vision grades are able to maintain throughout the day or not. Everything comes with certain component or a definite reason to it. Now, as an optometrist, we believe, I'm sure all of you also believe that component, which will be in future slides coming up. However, before we get into that component, there are different theories that talks about why intermittent exotropia develops. So prominent one, as there are always some theories backing with literature. So innervational factors, which was described by Professor Duvan, it talks about that unequal innervation at different point of time coming to the visual system, and that's why patient tends to develop intermittent squint. But Professor Belchowski described, no, it is more of mechanical in reason. What mechanical component? It is related to the length of the extraocular muscles. It is more towards the shape of the orbit or the size of the globe or the orbital fat or the tissues. So many factors, but nothing is conclusive. why I put this together, if you want to go by the management, then knowing this etiology is very important. Let's believe the optometry component, which is more prevalent or which is more scientifically, I would say, validated, is where the functional faulty reason and the refractive error and ACY ratio plays a major role. Now, if you look at any intermittent XTs, all of us, we born, or most of us, I would say almost 60 to 70% of the newborns are actually develops with certain amount of exophoria, a very small angle of exophoria. Now, by the end of 4 months, that tends to get off or tends to get corrected. And we exactly know why it happens, because that is the time patient develops their higher grade of binocular vision, and like the stereopsis is coming at that point of time. So if you are able to hold your both the eyes together, the fusional component and the stereopsis, your exophoria goes off. So that's why if you think that the patient, the residual component, we have seen the prevalence of around 3% of population is actually having intermittent exotropias. Most of them would have a faulty fusion. And moreover, myopes who has tendency to accommodate less, they have higher chances to have intermittent XTs. And if it is pure fusional divergence excess kind of thing, then you see they tend to have high ACY ratio. So when they are looking at near, their ACY ratio is playing a role to maintain the BSV. The moment it is far, you see they're having a divergence excess type of intermittent XTs. Now, knowing this etiology makes it more easy for us to manage. I'll be restricting my presentation more towards optometric management, how we can tackle this fusional faulty fusion or refractive correction or taking care of high ACY ratios. Just before that, as we're discussing about the etiology, so there are 4 types. The basic one is where the distance and near deviation is same. So you do evaluate, you get the same kind of evaluation, or less than 10 diopter difference. If it is convergent insufficiency type, that means near deviation will exceed by 10 diopter, 10 prism diopter than the distance. And divergence excess is opposite. So the distance deviation will be more than the near. And pseudo-divergence condition, when you primarily fail, or before a patch test, you see that they have a divergence excess type, but the moment you do a patch test, you see they are having similar amount of deviation. So they're actually not falling into divergence excess. It's a kind of basic intermittent XTs. All of this is leading me to this kind of issues, why we are concerned, why you want to manage this patient with some intervention. So all IXT patient, whenever there is a deviation coming, whenever the deviation is manifesting, they tend to lose the depth. And this is more critical because any kind of work today related to whether it's sporting activities, routine day-to-day activities like walking staircases, anywhere, you need a good depth perception. The moment IXT comes into place or the deviation comes in place, the stereopsis goes off completely, and that leads to problem. Cosmetically, it is very, very difficult for somebody to get used to. You see a lot of people are with IXT don't go for a selfie, as in they don't like to take a selfie from themselves, so are restricting themselves socially. Their performance in academics and sport, everything is affected. They tend to get into abnormal head posture, and overall they becomes very, very unhappy with the outcomes or with the present condition. And there is a lot of psychosocial that is impact that creates by intermittent XT itself. Let's see how we can manage them. So today there are different theories, as I spoke about, so different management modalities. Somebody would say, okay, let's do intermittent patching or a alternate patching to one of the eye. If the cause of IXT is a faulty fusion or related to high ACY ratio, it is really doubtful how your patching, alternate patching is actually going to built upon the fusion or help to correct the IXT. So it's a question, always question, though people are practicing. Surgical procedure, yes, majorly performed when it is a decompensated nature, when the stereopsis is affected, then the people tends to do, or as primary choice is to do a surgical intervention where alignment of the medial rectus, they would actually tighten, or the lateral rectus, they will recess it. So different ways that they can do. However, the major complication comes with a surgical procedure to have a recurrent or a executive one. Strabismus are most common that we have seen a patient developing dissociate vertical and horizontal deviation, and that becomes more challenging later on to manage. There are a scope of prescribing minus lenses like overcorrection, but Rizwana ma'am clearly spoke about how overcorrection can lead to other problems. So I'm not going into that. And the major portion, the bulk of it, actually done by optometric way, which is binocular vision therapy approach. You can manage this patient. Let's see what all we can do in a vision therapy approach. You can actually get a good compliance. That can be a combination of many things, which will come in one by one. And then it helps to develop good binocular vision, stereopsis. And in cases where the surgery is already being done for decompensated squints, you can help them to build and prevent the recurrence. So these are the different phases where the binocular approach would work. First is optimal correction of refractive error. Never intend to give a over minus, though it helps to accommodate and do a convergence takes place. But if it is truly high AC by A ratio, you can help them. Otherwise, not what of prescribing. And then counseling of the patient is very, very critical. You ask them that, grade them, how the squint is varying. Newcastle classification is one of the critical tools that you can use. So counseling is very, very critical. And then in the phase 2, the task is going to be eliminating the separation, develop fusion. Now, when you are trying to eliminate the separation, you need to make this patient aware of their physiological diplopia. Try to teach them how to observe this double vision or a physiological condition so that the brain is constantly forced to keep it single. So there is a book, obviously, by Dr. Rizwana, which talks about how to keep it single in a simple way. And this is the best way to learn how to see a physiological diplopia, and brain can actually fuse whenever there is a tendency to deviate the eye.
Sorry, Mr. Oliula, just a gentle reminder, 1 more minute.
Sure. And in the third phase, your task is to develop a good stereopsis and train their fusional vergences with jump actions. There are different approach. I'm sharing our experience with binocular approach in IXT patient. So a typical case of patient having combination of IXT and mild form of amblyopia, which is very common in a meridional component, with a poor control and saying yes, distance vision. With the optometric approach, binocular way, you can develop not only their best corrected visual acuity to improve, you can gain good control and that stereopsis. So key to success is to develop a distance and near stereopsis to a highest level. And this is summary of our results, which is due for publication. As you see that even 8 weeks of binocular vision therapy can help them to improve the stereopsis drastically and also improves the control of the strabismus at any given point of time. And in this way, when you have a clinical evidence, more and more things are coming up in the binocular approach. I would advocate that one thing that we can start with, that train the patient how to see double images and let the brain control how to prevent the double vision. That's the take-home message. Thank you.
Thank you, Mr. Oliula. Now let's welcome Dr. Rizwana.
Dr. Tiong, Ms. Carla Lanka, and Mr. Oliula for the panel discussion. All participants, please stay tuned for the exciting quiz at the last session of this webinar. I am pleased to invite Ms. Ons Luhemel, President of Tunisian Orthoptist Association, to chair this panel. Over to you, Ms. Ons. Can you please unmute?
Thank you for the invitation, and happy to share with you the World Optometrist Day. So we start with Dr. Rizwana, and to ask you, what do you think about the? Do you think that the binocular vision as assessment should be part of the workup in optometry care practice?
100%.
Yeah. Okay. So then we move to.
Yeah, that's why I showed the prevalence, right? It's like the prevalence of binocular vision is as high or more high than myopia and the other conditions that we are paying attention to. So definitely yes. And even in myopia, for that matter, without doing binocular vision, we may not be able to decide on the right choice of correction for myopia control. So yes.
Thank you. Then we move to Dr. Tiong. Is the binocular vision important in determination of refraction?
Sorry, just say that again.
Sorry?
Can you just repeat? Yeah.
Okay. Is the binocular vision important in the determination of refraction?
Absolutely. So I always would do some, so if a patient comes into my office, the first test I would do is a cover test. It's just so important to have a look at the eyes, just taking a look whether there's a fovea, even though they don't have atropia, but just take a look if the fovea were to have a tendency of breaking down. That gives us some idea about prescribing glasses for them. So sometimes we might want to tell them that it's more important to look into the functional aspects of vision rather than just getting glasses itself. So sometimes even like if you're going to change the prescription, having to know their binocular vision status allows us to prescribe them more appropriately.
Thank you.
Thank
with Dr. Carla, for how long do you train eccentric vision?
We usually have a plan. There's no guidelines, so I think all over the world, many orthoptists, optometrists, they choose the one that best fits for them. So we found that for us, the one that fits better is 4 sessions. So the sessions should be done in a row. So it will be 4 weeks, so about 1 month. So there are some patients that can take a bit longer, but usually 1 month.
Thank you. Then the last one with Dr. Olila. What test do you usually use to diagnose simultaneous intermittent exotropia?
To check which which parameter? I missed that point.
To diagnose in exotropia, intermittent exotropia, which test do you use usually?
So yeah, there are quite few of tests you need to do to rule out any other condition. To typically diagnose intermittent XT, you need to do a cover test for distance and near, Prismberg cover test. Look for the component or deviation. You need to do a small patch test and check what the deviation is happening post-patch test. Check AC/by ratio to rule out any other issues. As I mentioned, the divergence excess type typically would have high AC/by ratio. And then obviously the basic refraction is very, very critical. And that needs to be done a proper way as taught by today also by re-insisted by Dr. Rizwana that you need to do a proper refraction before you can get into any kind of diagnosis or jumping into any other conditions.
Okay,
Thank
thank you.
you. Thank you so
Thank you.
much, all the panel speakers and everyone. So let's move on to the next session. Thank you.
Hello to all, I am Ujjwal Kumar Roy, working as an optometrist with Moorfield Eye Hospital, Abu Dhabi, and a UF member. As we have completed the binocular harmony, let's move to our third session, where our esteemed speakers will take us through the new technologies and the perspective of vision care. Over to you, Jabir from UK studio.
Welcome all. My name is Jabir Mohammed Jafar from Medcare Eye Center. I am a member of United Optometry Forum. Our first speaker is from the land of world's oldest eye hospital. I would like to invite optometrist Dr. Abhishek Mandal to talk on use of AI in transforming eye care. Over to you, Dr. Abhishek.
Good morning, good afternoon, good evening, wherever you are from the world. I would like to extend my heartfelt thanks to Mr. Swarnakamal and the esteemed members of the United Optometrists Forum for this gracious invitation to speak at this significant event. It is an honor to be here with you all on the special occasion of World Optometry Day. To each one of you dedicated professionals, students, or enthusiasts who play a pivotal role in this vital field, I wish a very happy World Optometry Day. I deeply regret that I couldn't join you live due to my ongoing travels and the challenges posed by internet connectivity. So, today, as we gather to celebrate the impact and importance of optometry, let's also look forward to the innovations and advancements that lie ahead. So, thank you for having me. Today, as we are embarking on a journey to explore how artificial intelligence is not just revolutionizing the eye care, but is also steering it towards a more sustainable and greener future. Let's delve into how AI is the linchpin in the transformative era of healthcare. As we delve into the realm of eye care, it is crucial to acknowledge that the environmental footprint left by this industry, let's say from the plastic waste generated by discarded contact lens and eyewear to the extensive sources consumed during the production, the impact is vast and multifaceted. Each year, millions of eyeglasses and contact lenses end up in the landfills and oceans, contributing to the growing problem of pollution. However, this also presents us with a significant opportunity. By shifting towards more sustainable practices, we can not only reduce waste and conserve resources, but also take a step closer to safeguarding the planet for future generations. The importance of sustainability is paramount in eye care and cannot be overstated, as this offers a path to a greener and a more responsible future. Artificial intelligence is transforming the eye care in unprecedented ways. At the forefront, AI driven diagnostics employ sophisticated algorithms to analyze scans, offering earlier and more accurate detection of various eye conditions. This leap in diagnostic capabilities not only improves the patient outcome but also enhances the efficiency and reduces the waste in healthcare delivery. Moreover, AI takes personalization in eye care to the next level by analyzing extensive patient data. AI systems can tailor treatments to individual needs, ensuring that each patient receives the most effective care possible. This not only elevates the standard of care but also contributes to the sustainability by reducing unnecessary treatments and resources. The rise of AI powered telemedicine has also revolutionized access to eye care. Through virtual consultations, patient can receive expert delivery of patient care without the need of physical travel, greatly expanded access to remote and undeserved communities while simultaneously reducing the environmental impact associated with healthcare delivery. Together, this advancement showcases AI's pivotal role in enhancing the quality, accessibility, and sustainability in the eye care sector. In our quest for sustainability, reducing waste is paramount. AI emerges as a powerful ally in this endeavor within the eye care industry. By accurately predicting demand, AI ensures that the production of eyewear is closely aligned with the actual market needs, which significantly curtails the overproduction and excess of inventory. This not only conserves the resources but also reduces the waste that often ends up in the landfill. Packaging is another area where AI is making a substantial impact. Through innovation designs, algorithms, AI is creating smarter packaging solutions that require less materials, thereby diminishing the waste footprint. These smarter designs maintain integrity and safety of eye care products while using the minimal necessary packaging. And when it comes to recycling, AI is transforming the landscape yet again. Sophisticated sorting algorithms and robotics powered by AI have enhanced the efficiency of recycling programs. They enable the more precise sorting of materials, ensuring the components of eyeglasses and contact lenses are recycled correctly, thus extending the life cycle of the materials and supporting a circular economy. By integrating AI in these key areas, the eye care industry is making significant stride towards a more sustainable future where waste reduction is not just a goal but a reality. So as we continue to innovate for sustainable future, AI is proving to be invaluable asset in boosting energy efficiency within the eye care sector. AI systems intelligently manage facilities, operations, controlling energy use of lighting, um, then we have got the heating and cooling based on real-time data, thereby slashing the energy consumption and costs. So as we can see, we have got cost efficiency consumption of less consumption of energy, which is energy efficient as well. In the manufacturing realm, AI's powers is analyzing vast amount of production data streamlines the manufacturing processes of eyewear. This not only enhances the operational efficiency but also significantly lowers the energy use, contributing to a reduction in the industry's carbon footprint. Furthermore, the supply chain and traditional energy in intensive aspects of the industry is undergoing transformation. So, thanks to again to AI, by optimizing logistics, AI ensures that products are transported and stored in the most energy efficient manner possible. Well, this leads to a decrease in the energy required for the transportation and warehousing of eye care products, showcasing AI's extensive capabilities in the in creating a more energy conscious industry. The role of AI is enhancing energy efficiency in a testament to the technology's potential to aid the realization of a sustainable and eco-friendly eye care industry. Let's move on to the telemedicine part. So, telemedicine is one of the most transformative impacts of AI in the realm of eye care. The power of AI to facilitate remote consultation has not only made eye care more accessible to people in remote and undeserved regions, but also significantly contributed to the environmental sustainability as well. By reducing the need for physical travel to clinics and hospital, we are witnessing considerable decrease in the carbon emission. This shift is not only representing a leap forward in making healthcare more inclusive, but also exemplifies how technological advancements can harmoniously align with our sustainable goals. As we continue to embrace AI in eye care, we are not just improving patient outcome, we are also taking a step towards a greener and a more sustainable planet. Let's explore how this incredible synergy between AI, telemedicine, and sustainability is paving the way for a future where access to eye care is universal and our environmental footprint is minimized. Let's illuminate the tangible success of AI-driven sustainability in eye care through inspiring case studies. One clinic's story stands out where smart diagnostic AI tools have significantly cut down diagnostic errors. This has not only boosted patient care but also conserved valuable resources. In the world of eye care production, a pioneering company has embraced AI to design a 3D printed glasses. This process has revolutionized the production efficiency, cutting down material waste remarkably and setting a new standard in sustainable manufacturing, turning out to be more sustainable and efficient way of managing the global problem, which is the problem that we all are facing. So, turning our gaze to hospital management, a notable case is that of an eye hospital that employed AI for meticulous management of resources. A staggering of 30% in the West demonstration of AI's proficiency is ensuring the sustainable operation. The profound impact of AI-powered telemedicine initiatives cannot be overlooked. One such program has made eye care accessible to remote populations and significantly reducing the carbon footprint by eliminating the need to travel. These case studies are a beacon showing how AI innovation applications are not just theoretical but also making a real difference in pushing the boundaries of sustainability in eye care. As we embrace the transformative power of AI in eye care, we must also navigate the challenges that accompany this adaptation. One of the foremost concerns is the privacy of patient data. As AI systems handle more of the sensitive information, the need for the ironclad cybersecurity cannot be overstated, isn't it? Ethical considerations are also at the forefront. We must be vigilant about the algorithmic biases that could inadvertently affect the quality of care delivered to diverse population. Ensuring a fairness and equity in AI application is not just a technical challenge but is more moral imperative. Moreover, the integration of AI into eye care must be done in a manner that enhances, not diminishes, the role of human professionals. AI is a tool to support decision making, not to supplement the critical and nonsense judgment of experienced practitioners. Lastly, the regulatory landscape of AI's healthcare is continually evolving. Staying informed and compliant with this regulation is vital to maintain the highest standards of patient care and safety. The path forward is one of the cautious optimism. By addressing these challenges head on, we can steer the future of eye care towards one where AI plays a role that is both transformative and responsible. As we stand in the crossroads of innovation and sustainability, the call to action is clear and urgent for every one of us. To industry leaders, now is the time to invest in AI technologies that pave the way not just for advanced care but also for sustainable future. Your commitment can lead to transformative changes that benefit both our health and our environment. To the dedicated professionals in the eye care industry, your role is pivotal. By adopting and advocating for AI driven practices, you can help reduce the ecological footprint of our field, setting a new standard for care that respects our planet. To the consumers, your choices have power. By supporting brands and practices committed to sustainability, you drive the demand of innovation that values the world as much as our well being. And to everyone, let's raise our voice for the cause. Spread the word about the critical role of sustainability in eye care. It's through our collective efforts that we can achieve a meaningful and lasting impact. Together, we can chart a course towards a future where eye care not only looks after our vision, but also the world we hope to see clear for generations to come. Let's embrace this journey with hope and determination. As we conclude our journey today, we reflect on powerful intersection of artificial intelligence and sustainability within the eye care industry. AI is not just a tool for innovation, it's a catalyst for change, pushing us towards more sustainable practices from reducing waste and energy consumption to the broadening access while minimizing the carbon footprint. Yet this journey is not without challenges. We need to remember that data privacy, ethical consideration, and seamless integration of AI into existing system remain a paramount as we move forward. However, these challenges also presents us with opportunities to innovate, to rethink how we can approach eye care, and to redefine what is meant to be sustainable. As we come close to this presentation, I would like to express my sincere gratitude again to the organizers for the event, the United Optometrists Forum. for the opportunity to share insights on AI-driven sustainability, transforming eye care for a greener future. Again, I deeply regret that I couldn't join you live due to my ongoing travel and challenges posed by poor internet connectivity. Should you have any questions or wish to delve deeper into any of the topics discussed, please do not hesitate to reach out. I encourage you to email me your questions or thoughts, and I will be more than happy to engage in further conversations and provide additional insights. Thank you once again for your understanding and for joining me in this vital conversation. Let's continue to work together towards a sustainable future in eye care, leveraging technology not only to improve patients' outcome but also to protect our planet. Thank you very much.
Thank you, Dr. Abhishek. Now I would like to call our next speaker, Dr. Mohammed Al-Kedbi, who hails from the safest country in the world, proudly UAE, and he would be educating us on the new color vision testing method, Ionica. Over to you, doctor.
Good evening, everyone. Happy Optometrist Day, International Day to everyone. I hope you all can hear me. If someone can signal if you can hear me or no, so I can start.
Yes, doctor, we can hear you.
Perfect.
Loud and clear.
So I'll be explaining to you today the Ionica's color vision evaluation test, or the Ionica's CVT. I'm a consultant ophthalmologist at SKMC Hospital Abu Dhabi, and I have participated partially in this kind of research. I'll present the paper at the end to you. So I was involved in this sort of testing occasionally. I like to always start by mentioning our Hippocratic oath that tells us, before you heal someone, ask him if he's willing to give up the things that made him sick. And to speak about the light, color, chromatic values and psychological dimensions of color and physical dimensions of color, which are important. Sir Isaac Newton was the first one to be able to separate the light spectrum into its spectrum colors through the prism, and he was able to do further studies by removing it, changing it to spectrum, and returning it by an inverted spectrum or prism to white or broad spectrum light. And through that, he was able to study many values and entities of light. So the physical dimensions of color depends on light source and reflectance. Of course, it has many other things. These, I'm speaking about the physiological part of or physical part of the light. The reflectance, meaning on the objects as we see the light or the tone or the wavelength of the light falling on an object and returning to the eye. So the light itself, source, the color or the wavelength will matter as much as the reflectance or the color of the object itself where the light reflects upon. And hence mixing these two, coming to our eyes and causing us to see these things by other means that I'll explain in a bit. And the psychological dimension of color, it has three parts: hue, saturation, and brightness. And these are important to further explanation of this Ionica's test that I'll explain in a bit. Color deficiencies in general that are monochromatic, and they are the real absolute type of color deficiency. These patients don't see any color actually. So they don't have any cone function almost. They work or function on rods and they see shades of gray, white, black, and shades of gray most of the time. Dichromatic patients, there are three types of dichromatic patients. Protanopia, which has a deficiency in L cones, and deuteranopia, which has deficiency in M cones, and tritanopia, which has deficiency in S cones. So protanopia is present in 1% of males and 0.2% of females. Deuteranopia is present in 1% of males and 0.1% of females. And tritanopia is 0.002 in males and 0.001 in females. Anomalous trichomats and unilateral dichromats are other types of also color deficiency. And there is an entity called cerebral achromatopsia, which happens normally post-surgically or post-tumoral or therapy or radiotherapy or post-trauma as well, or injury and insult to the brain. The protanopia, the wavelength that they see actually is between 492, 94, and below that they see blue, and above that they see yellow. If they're exposed to the wavelength, I mean. Deuteranopia is 498 nanometer of wavelength. That's where they see gray, actually. And then below that, they see also more or less blue, and above that, they see yellow. Tritanopia, they actually see gray at 570 nanometers wavelength, and below that they see red to blue and red to green, sorry, and no, sorry, red to blue, below that, and above that wavelength they see actually yellow as well. So the anomalous trichomat and unilateral dichromat, these can have different sort of perception of color in each eye. So this can create also problematic for the patient, and they should be diagnosed and tested separately. Hence, they should be diagnosed and tested separately. The test of Ionica, of course, it is test that I'll explain at the end. My perception of it in globality, but it was developed by Dr. Virgil Ionica, who's a practicing ophthalmologist up to today. I had the chance to work with him in Nice, France. That he was the one that developed and established this test uniquely for the screening and testing, fast testing of children. Since the other available tests were strenuous and they will take lots of time, and most of the time the patient will not understand it depending on their age. So he developed this test to be able to test ages of up to 3 years. I think from 3 years even. They started up to from 3 years onwards. I'll explain how is this test and what does it consist of. The CBT Ionica's test consists of an album of 72 cards, 416 colors, and 68 testing plates with 10 grading of saturation in each page. So it combines the hue and the saturation. The lamp that comes with the test itself, it's a table with a lamp on it where you can put the album, and you can observe the rendering index of this light bulb is fixed. It's 98 and the color temperature is 4,500 degrees, and the lightning intensity is 1,600 lux. The software program that comes with it that we will discuss as well towards the end. So the test consists of this piece of paper, the small one towards upper left side, that looks like a chair or a stool. The patient will have these cards, the testing cards, the first 4 cards, to learn how to do the test. So they will explain to them that you have to put the chair in the same orientation as the drawing. And the test will start after these 4 small cards. And the patient will be able to change the orientation of this stool or chair as we go along the test. Each card after will have different colors depending on the axis tested, and different saturations. And the luminosity will be fixed in this case, since it's coming from the same lamp and the same distance from the lamp and the test table, which has a fixed album on it. So this test will be graded from -2 up to 0.9. So from 0.1 up to 0.9, these will be considered more or less normal, and we'll grade the patient which one the patient was able to read the maximum on each plate or on each page. So, and we'll sum it up later. So there is a collection sheet for this data while we go along with the patient while they're doing the test. 0 to -1 and -2 is to define the axis of so the other ones is more or less similar to the Ishiaras, and the other 0 to -1, -2 is to define and localize the axis of deficiency, which axis of deficiency we have in this color deficiency or color blindness. And we chart it normally on a chart like this one. Depending on the data we have, either we chart it manually, depending on the data collection sheet, which is very easy and goes smoothly, and you just mark it here and paint it or highlight it like a spider web between the axis and the maximum axis you have is where is your most likely axis is gonna be. So some of the spider web will be linked to the protanopia, tritons, or other places. But if it goes to 0, -1, -2, it will define which anomaly we have exactly. So the results of this study that we have conducted to compare, it was a non-inferiority prospective study that showed a mean age non-inferiority between Ishiara, the 15 who Farnsworth test, and this CVT Ionicus test. So the patient means age was
Doctor,
7.
sorry
Yes.
to interrupt. You have 1 minute to wind up.
No worries. So the mean age was 7.5 plus or minus 3.5 years of age. This chromatic group in the control group was slightly higher, but the test, the first evaluation sensitivity and specificity was 95 to 96% respectively for the CVT, while for the 15 who test was 75 to 58%, which was significantly different. The reproducibility of the CVT test was 100%, while the 15 who test was 88.4%. The mean test explanation duration was very little, comparatively was not statistically significant between both tests, and the CVT was always significantly longer to take the test than the 15 who test. But considering the specificity and the sensitivity of it, it was worth more to do the CVT test. The children globally conducted the study preferred to undergo the CVT test as it was easier, and they preferred it over the 15 who test in 84% of the cases. Conclusion of that study, that was the CVT test was very rapid, reliable, and reproducible test for the diagnosis of congenital dyschromatopsias, and it was accessible to young children. This Dyschroma software, finally, it's my final slide. So it's a software that will enter the data that we have from the sheet, the collection sheet, and the diagnosis sheet, and it will generate images for us for each eye, comparing it to the natural image to be able to explain to family members and to be able to see with the patient's eye as well and understand their problem in daily life. So it generates an image of something like you see here, that there is a difference between the right and left eye and compared to the C up, which is the natural image. This paper was published, and I was part of this study in 2021 in American Journal of Ophthalmology. If you want to have a more depth in more detail about it, and we'll discuss later of any question. Thank you.
Thank you, Dr. Al-Kadbi. Now I'm standing in our Indian studio, the land of colors and birthplace of ophthalmology star rock, Dr. late S.S. Badrinath. I would like to call Dr. Rajiv Prasad to share new perspective on low vision rehabilitation. Over to you, Dr. Rajiv Prasad.
We can't hear you.
Hello, am I audible?
Yes, carry on.
Yes, sir.
Perfect, great. So, good morning, good afternoon, and good evening to some of you. Thank you, United Optometry Forum, for having me today with you all, and wish you all a very happy World Optometry Day. On behalf of Indian Optometric Association, Asia Pacific Council of Optometry, and World Council of Optometry, I wish all a very happy World Optometry Week to all my fellow colleagues. So today I'm going to talk a little bit on different perspective of low vision. So we all know that the term visual impairment compasses of two major groups. One is low vision and one is blindness. Low vision, as a definition, we all know that it is visual acuity less than 618 equal to or better than 360, corresponding vision loss less than 20 degree in the better eye or with best possible correction, and blindness visual acuity less than 360 with corresponding visual field loss of less than 10 degree in better eye with best possible correction. Common causes in developed nations is 50% is due to age-related macular degeneration, and rest because of glaucoma, diabetic retinopathy, cataract, and definitely URE is another cause. In developing nations, developing countries, beside uncorrected refractive error, it is more about cataract and other infectious diseases like xerophthalmia, injuries, glaucoma, and so on. So if you go through the visual impairment as a perspective and their effects on individual entire life, their social, occupational, recreational, family life, everything gets impacted. And blindness of all chronic illness and disabilities is the second leading cause of inability to work. Usually one thing we usually miss out when we talk about low vision is we definitely work more on quantity of vision, how many lines a patient is able to see, but we really don't much care about the quality of life of people with visual impairment. So vision loss can affect one quality of life, independence, mobility, and has linked to cause injury, worsening mental health, cognition, social function, employment, and educational attainment. And the economic impact of those vision loss is also substantial. So individuals with visual impairment experience more symptoms of depression than those without. So it is not only the vision which is impaired, it is, there are things which is much more beyond that. So it is, it impacts your, vision is impaired, then activity, your participation in social group and everything gets impaired. So when we talk about rehabilitation, this is something very new which we just tried and it really worked out. So I'll be sharing on that. So in low vision, traditionally, we talk about different kind of devices, optical devices, non-optical devices. And, to improve, we give laser tint and all other stuff. But I just tried, to integrate neurooptometry along with low vision because I had been doing low vision for almost more than 2 decades now. And it really worked out to be a really great one. So neurooptometric rehabilitation is a specialized branch of vision care that focuses on visual rehabilitation of individuals with various visual dysfunction, especially those resultant from neurological conditions or trauma. We all know these recent innovations in low vision aids, which is, Pelley's field expansion prisms, which is little different than Fresnel prism, telescopic contact lenses, telescopic intraocular lenses, electro-optical system, talking global positioning system, GPS, smart cane devices, microperimetry, retinal processes, Argus 2 retinal processes, retina implant, brain port, stem cell, definitely everybody is working on, and platelet-rich plasma therapy and gene therapy. So what is the unique part of, significance of neuro-optometric rehabilitation? So neuro-optometric rehabilitation plays an important role in improving the quality of life for an individual who has experienced vision loss or dysfunction due to neurological issues, and it is crucial to addressing the visual impairment that can result from a variety of conditions, and which the deficits includes eye teaming, focusing, tracking, and visual processing. And the aim of the low vision and neuro-optometric rehabilitation is to enhance a patient visual ability and overall function vision, which can significantly impact their independence. Some of the low vision devices which traditionally we use in our practice. So the key goal of low vision and neuro-optometric rehabilitation is to enhance visual acuity and clarity of the patient, improve eye-hand coordination and teaming, enhance depth perception, develop visual tracking and scanning abilities, and address specific visual need identified in the assessment. So the key components comes is, ocular motility exercises, visual perception training, BV activities, and other stuff. Other goals are, the duration and frequency. Vision therapy programs, low vision therapy programs are tailored to individual needs. Typical sessions are held weekly, and a duration may range from several weeks to several months, which we have done. Customization, monitoring the process on a regular basis. Complex nature of visual, the challenges and limitations are complex in nature and of visual impairment, limited awareness and accessibility, compliance and patient commitment, coordinated care, and resources constraints. So the challenges goes on with patient expectations are too high because they have been denied for the treatment from all over the places, and they somehow in low vision and neuro-optometric rehabilitation they found something that can help, so expectation becomes really high. There are less researchers in this area. More research is needed to further understand the neurological and visual aspects of rehabilitation. Evolving technology, a lot of things are coming, and interdisciplinary collaboration. Cultural and language barriers, patient-related factors, legal and regulatory framework. Still the definition what we use for low vision needs to be updated and changed. Patient support network. So a small-scale study published in journal in 2018 found that 100% of the participants experienced improved eye movement and peripheral awareness in 10 hours of low vision optometric rehabilitation. And there are several studies to support that. The future directions in this area talks about incorporation of artificial intelligence, which my previous speaker, Dr. Abhishek Mandal, spoke about, telemedicine and remote rehabilitation, virtual reality and augmented reality, and neuroplasticity research. Interdisciplinary collaboration, patient-centric care, global outreach and accessibility, and research and education. Now, I would like to share with low vision patients, and it really worked out to be a great one. So this is a 20-year-old female with field multifocal choroiditis. We started working on, stimulating the neurons, which is still was active after getting, OCT macula and visual field and multifocal ERG done. So she presented in right eye with 3/60 and 2/60 vision, and near was N36. We did 30 days, in office neuro-optometric rehabilitation thing from March to April, and with the correction, the optical correction changed, but the improvement was significant. So in right eye, she improved from 360 to 636 partial and 260 to 618 partial. And stereo acuity, which was flat, it started with 800 seconds so far. Next patient, as you can see, You can see the below pre and post visual field also. So this is 26-year-old male from Punjab with RP, 15 years. He has been struggling with reading, writing, and he lost his confidence. Mobility was a challenge. He was bumping into objects, difficulty with night vision. Treatment approach started, we started with this treatment option, of neurooptometric stimulations and all, and focusing on improving the peripheral awareness and visual acuity. And to our surprise,
Sorry to interrupt, doctor. You have 1 minute to wind up.
Sure. Thank you. So from 636 to 618, left eye from 618 to 612 partial binocularly, it was 6/9, and improved near vision was N12 to N6. And third and last case, 71 years old male, both eye cataract operated, diabetic, hypothyroidism since long, both eyes pseudophakic. And with this process, in almost 25 days, 2 sessions a day, right eye from 2/60 and left eye from 618 improved to 660 and 612, and near from N36 to N10. So this is some of the cases which we have done. So thank you all, and thank you for giving me this opportunity on this wonderful day. Thank you so much.
Thank you, Dr. Rajiv, for your insightful presentation. And now let me welcome Mr. Ram Krishna Salunke. He's an optometrist working with American Hospital, Dubai. And he'll be chairing the panel discussion for this session with our eminent speakers, Dr. Rajiv Prasad and Dr. Mohammed Al-Ketbi. Please join the panel, sir. And Ram, the mic is yours.
Yes, thank you, Ujjwal. And thank you, presenters, for wonderful insights on the given topics. I wanted to ask, I think, Dr. Mohammed Al-Ketbi. Can you hear me, doctor?
Yes, I can hear.
Yeah, thank you. So, wonderful talk. This is something new in the region. This Ionicas, the color vision. I wanted to ask the accessibility of this test in the region, of course, in GCC and the rest. How is it? Number one, and number two, I wanted to ask you from the civil aviation, from the GCAA point of view, we have these pilots coming in for the assessments. How reliable or how accurate results we can get with these pilot color vision assessments?
It is not a pilot. It's actually used already in France extensively. They use it in all the centers for diagnosis, and it gives you the access and sensitivity and specificity is the highest for this age group. So this test actually combines the 100 Hu, the 15 Hu, and some parts of the Zeitz tests and other tests. So what he did actually is take the other tests, combine them in one test, and make it ludic, make it like a game for the children to be able to follow. And it became very specific as he put the contrast that's variable in each sheet. So with different colors axis, there was different contrasts in the same sheet. So he will be able to trace it in the same sheet. And they did actually the tests twice, the Ishihara, the 15 Hu and the CVT. And it was very 100% reproducible, on the contrary of 15 Hu, which was confusing. And actually what we noticed during the study, that the time of the test increased in the 15 Hu in the second time, but for this test, it reduced as it's ludic actually, which makes more sense. The only test that's more sensitive and specific than this is the anomaloscopes and other electronic tests that you have, but therefore for the children, it's very difficult to assess. The point here being that if you diagnose earlier, you will know the problems for the child, and you will be able to help them during their schooling and education. So it's very useful, at least for now. As for the classification or the studies you're mentioning and the The guidelines, I'm not aware if they're including this one or not. But accessibility for this test, you can buy it online. It comes with the set, the catalog. You can get the Dyschroma lamp with it, and the software was provided on a CD. And you can use it for parents' education and for yourself as well, and for the child if you find them a solution for the dyschromatopsia, of course.
Thank you, Dr. Al-Kedbi, for your input. I think Dr. Rajiv, we have one question for you from one of the attendees. Yeah, typically he's asking, for patients with the active lifestyle and having usually binasal and bitemporal heminopias, homonymous heminopias, how do you typically manage these patients? I think you're muted, so you have to unmute.
Yeah, is it better now?
Yeah.
So usually for people with heminopias, the best is go with Fresnel prism. Fresnel prism is one thing which really helps with for these patients. But yes, beside that, if I say one prism which I mentioned during my talk also, which is the Pelli's field expansion prisms, which doesn't have that multiple prism, so that also works really, really well. And that the cosmetic issue of that lining on that due to Fresnel prism, that is not there. So that really works well. And beside that, in heminopia, you can also work on rehab area in terms of training the patient about scanning, tracking movement, they're using their head movements and all. But in neuro-optometric, ever since I've started merging low vision and neuro-optometric rehabilitation, I mean, we work more on peripheral awareness, and that really works. But it's a little time-consuming process, but it really works.
Thank you. Thank you very much.
Ram.
Thank you, Ujjwal.
Thank you, Ram, and Dr. Al-Kedbi and Dr. Prasad for clearing some of the doubts. And for the viewers, if you have any questions with Dr. Abhishek's presentation, you can just put it in the chat box. We will try to address it later on. Now, here, let me remind you all, you guys can participate for the quiz session that we are conducting towards the end of the session and towards the end of the event. And please remember to register for October's 5. Now, I would like to invite Mr. Tanios Kejol, training manager at Amico. He will talk about the opportunities that astigmatic patient can bring to our practice. Over to you, Mr. Tanios.
Please double check now. You're able to see it now. Please confirm.
Yes, it shows now.
Okay, perfect. So again, good evening, everyone, and good afternoon for some of you around the world. Again, my name is Tanios Georges. I'm the training manager for Amico Middle East. And our topic now is the opportunity to grow with astigmatic patients. So as we all know that astigmatic patients is a big part of our business. Imagine that 47 of the patients that you see them in your clinic, they are astigmatic, but only 10% of wearers, they are in toric contact lenses. So how it works is almost 68%, they are wearing only eyeglasses. As we all know that when people, they are wearing eyeglasses and contact lenses.
Mr. Daniel, sorry to interrupt. Actually, your presentation is still not visible.
Okay, so I'll try again.
Yeah, now it came actually. I think.
Now it's fine?
Yeah, now it looks fine.
Okay, perfect. So as I was saying that 68% of the astigmatic patients, they are having only eyeglasses. Nobody offered them contact lenses. And though they are, most of them, they are eligible to wear contact lenses. We as eye care professionals, whenever we see astigmatic patients with a minus 0.75 cylinders and above, we try, and sometimes we hide from talking about contact lenses because there is a lot of barriers. And also 22% of these astigmatic patients, we usually fit them with spherical equivalent. So they have high cylinders or minus 0.75 and above, but usually for different barriers, for different obstacles, we just fit them with what we have, which is the spherical contact lenses. And only 10% of these astigmatic patients, they are fitted with the right lens, which means with the toric contact lenses. And usually, because they have high cylinders or high powers, so we cannot fit them with something else, and we fit them with the proper lenses. But this percentage, which is a very low percentage, only talking about 10%, it's not coming out of the blue. It's coming because there is a lot of barriers that the patient and the eye care professional, they are facing whenever they want to fit any toric contact lenses. And that's why we have these low numbers. The part of some of these barriers, first is the share time. We always think that we need a lot of time from the practice, from the patient, from the eye care professional to fit somebody with toric contact lenses. So that's the first barrier. The second barrier is the availability and the service. So the contact lenses, they are not available in the practice. Sometimes the suppliers, they don't have the lenses, and we tend to forget about it. The third barrier is we always been struggling with fitting toric contact lenses. We always want a better comfort. We want a better stability of the contact lenses, and we're not finding these in the toric contact lenses. So again, one of these, this is the barrier. Always we're thinking that whenever I want to fit a toric contact lens, I need the trial lenses availability inside my store. I need to try this lens before I prescribe it to my patient. And again, this is one of the barriers. And I want as simple as that. I want an easy lens to fit. So if we look around the clock, those are the main barriers for the practitioner and for the patient. And that's why we have this low number. And during this presentation, we would like to show you that now there is new things in the market, things that will facilitate your life, will make these barriers an opportunity. And this needs, it will disappear throughout the upcoming 15 minutes that we have. So let's look to the design first. Because of the design, it's making a big problem for our practice and for our customers. So traditionally, all the toric lenses, they used to come with something we call prism ballast, where the prism used to sit at the low end of the contact lenses, and it works because of the gravity. So we used to make the contact lenses heavy at the lower end in order to be stable. But this thickness here, it's making a lot of problem because the thicker zone can lead to lower lid interaction with the lens on every blink, and it swings and rotate. Because with every blink, and as we said, we blink 14,000 times per day, and imagine with every blink, I was touching my lower lid with this contact lenses because of this thickness. Also, the thickness, the thick zone can reduce the oxygen transmissibility, and this will lead to redness and problems with with the lower lid and with a lot of infection to my customers. Also, the problem with this traditional prism ballast lens design is whenever the patient will rotate their head left or right as a 90 degrees, sitting on a television, on a couch, reading a book, or watching their mobile, the lens used to rotate because of the gravity effect. So there was a lot of barriers and there is a lot of obstacles when we were fitting this traditional prism ballast. But as we know, now in the market, there is a new technology of toric lens design. And one of them is the Precision Balance 8.4 lens design, which is available now in in a lot of companies like EyeQon across their toric portfolio, whether in daily disposable or in reusable. And the good things about this precision balance 8.4 lens design, that there is no prism effect. So there is this heaviness at the or thickness at the bottom. It's not happening anymore, and we're just stabilizing the contact the contact lenses by using 2 spots at 8 o'clock and at 4 o'clock. And the advantage now is that now the gravity is not playing any effect. It's just when we blinking, we're keeping this contact lens stable. So with each blink, I'm helping the contact lens to stay stable throughout the day. Also, now, since I don't have the thickness at the bottom, there is no interaction with the lower lid. The oxygen transmissibility at the lower end is happening very well, and I'm keeping the whole eye white and healthy. Also, the optic zone, because now, even with, with the prism ballast, we used to suffer with the low lights, especially at night, driving at night, reading at low lights, because there was not enough optic zone to cover the pupil dilation. Now with this new technology, even with low lights, even with driving at night, reading at low lights, there is enough optic zone to cover the pupil in low light. So the patient is having a wonderful experience even at night. And the most important part of this new technology that we need to offer it, we need to understand it so we can offer it to our customers, is the stability of this contact lens. So let me show you a quick video here to show and showcase the stability of the Precision Balance 8.4 in all head position. So we fitted this lady here with the Precision Balance 8.4, and we marked the contact lenses at 6 o'clock, 3 o'clock, and 9 o'clock, just to see if it's stable. So now she's having a straight head position. All contact lenses, they are stable in straight head position. So nothing here to mention. But the problem used to happen with the old technology is when the patient will tilt their head. And look here, this lady, she's laying down on the couch, looking at the television, reading a book, and as you can see, the lens didn't move because the gravity is not playing any effect here. And now she's doing yoga, she's at the gym, she needs to do a full head movement, and even then, as long as she's blinking, the Precision Balance 8.4 is keeping the lens stable, and when the lens is stable, that means a great vision and a good comfort. So we need to understand the new technology that is available now in the market. And the new technology is making our life as eye care professionals and the life of our customers a better life and a better experience. So this Precision Balance 8.4, imagine, it takes only a few blinks to settle down. A few blinks. So less than 60 seconds, the lens will take stable. So before we used to suffer, the lens needs to take a lot of time to stabilize. We need to take the time of the patient, the time of the practice, the time of the eye care professional, just to make one fit on the toric contact lenses. But now it is with a few blinks, the 100% of wearers, they will experience 5 degrees or less of oscillation with each blink during the whole day and from early morning till late at night. And what are the tools? The tools, they are very simple. Imagine you have everything inside the clinic to fit toric contact lenses. And you just need this spectacles to contact lenses power grid or chart. By having this chart inside the clinic, it's just a paper where you can do the conversion from the prescription or the eyeglasses to the toric contact lenses, and it's gonna take you a few seconds actually. Just go horizontally from the spherical power and vertically from the cylindrical power, and then where they cross, that's what you need to fit the patient with when it comes to contact lenses. And when it comes to axes, now the toric contact lenses, they are available in all axes, from 10 to 180, even the oblique axis. But we need to make sure that whenever we have 5 degrees, we need to make sure to offer which lens. Should we go higher or should we go lower? And let's take just an example. If I have a 15-degree axis, should I offer the patient a 10-degree or 20-degree? Just remember this rule. If it was in the right eye, round down. So just if it's 15 degrees in the right eye, we go to 10 degrees. And if it's in the left eye, we round up. So again, if it's a 15-degree and I'm dealing with the left eye, I should go for the axis of 20. So I go up. So right, I go down. Left eye, I go up. And I will have a perfect fit that with few seconds that I need to choose my contact lenses from spherical power to cylindrical to axis. And also there is now digital tools that it's available online for all the eye care professionals across the world, where you can just put the prescription or the eyeglasses and it will give you the contact lenses correction and also the brand that you can order in each country. So this is again a great tools available across the world. So now let's talk about the trial lenses. Should I have the full set of trial contact lenses in order to do a toric fit? And we all know that we have a lot of parameters. And how can I get all the trial lenses available in order to do one patient fit or one toric fit? This is impossible. But in the new technology, imagine 95% of the patient, you can fit them without trial lenses. 95%. So more than 9 out of 10 of your patient, you can just fit them with the new technology of toric contact lenses without a need to do a trial. You can, and companies are offering now a satisfaction guarantee. That's how great now it's becoming in toric contact lenses like Precision Balance 8.4. You can rely on the initial exam, just do the contact lens equivalent powers, and you go directly with the fit and the sales, and the satisfaction is guaranteed by the companies now across the world. So because the contact lenses are becoming so reliable. So what did we cover till now? Did we cover all the needs? We covered that with the new toric contact lenses, there is the reduced share time of maximum return. So I don't need to wait 10, 15 minutes for the contact lenses to stabilize. Lenses, they are providing comfort and stable clear vision. Because of the new design, there is no interaction with the lower lid, and also it's providing a clear vision in all head position. No need for trial lens availability. If you have the trial lens, that's a plus. But even if you don't have it, you can still fit toric contact lenses. And as simple as it is easy to fit. You don't need to bother yourself and take a lot of time off the practice and the patient. You can just go for an easy fit. But we didn't cover the availability and the service. The toric contact lenses will never be available in your practice. It will never be available. Why? Because we're talking about more than 4,000 powers. So it's impossible. It's to have all these powers inside your clinic, because the range of powers, spherical powers, cylinders, and axes, it can sum up to more than 4,000 powers. So if I want the contact lenses to be available inside my practice, this is going to be a permanent challenge. So what do we need to do? We need to stop what we are doing first. We need to stop giving spherical equivalent. Why? Because whenever we give a spherical equivalent, and let me summarize this study in front of us. Whenever we do a spherical equivalent for a patient who have a cylinder less than -1, so that means between -0.75 and -1 cylinder. If I do a spherical equivalent, he's gonna lose 3 letters from his visual acuity in the room lighting, which means in a good lighting. 3 letters. If I do a spherical equivalent, I'm losing 3 letters in the good light. But in the low light, the problem is gonna double up. He's gonna lose between 5 to 6 letters in a restaurant, at night, watching a movie, reading at night, watching his television with subtitles. So we are just fitting the patient with the wrong lens, and that's gonna lead for a bad experience, and then it's gonna lead for a dropout. So we're just wasting our time. And as you can see, the study, it continues. If we are fitting a spherical equivalent for a patient who has an astigmatic cylinder from -125 to -2, in good light and in low light, he's losing up to 11 letters. So we should first stop offering spherical equivalent contact lenses to our astigmatic patient. We need to offer them toric contact lenses. If we want to keep them in the category, we need to offer them toric contact lenses. And our advice, and this has been done by success models from different practices, is inside the clinic, whenever you offer contact lenses, please give them the two choices. Show them how they will see. On the phoropter, on the trial lenses that you are using, just show them the spherical equivalent vision, and then remove the spherical equivalent and just put the full correction, and you will see three letters coming out of their mouth. They will tell you, wow, because they were able to see by themselves the difference between the spherical equivalent and the full correction. And then you can ask them, do you want your contact lenses today? Now, I can give you, but you will not see very well because you showed it to them. And if you want to have the full correction, just let me call the company. They will deliver it in 24 hours and 48 hours. And then the patient, they will be ready to wait because they were able to see the big difference between the full correction and the spherical equivalent. So what we need to do is we need to make the availability, the challenge in the availability, we need to transform it into an opportunity because you are demonstrating that you are professional, because you are able to show your customer the difference between the spherical equivalent and the full correction. And by offering them the toric contact lenses, you are gaining their loyalty. I'm not saying anything new for you, ladies and gentlemen, because you know that your most loyal customers, they are the toric contact lenses customers. They always come back to the same store. They love you because no one has done this before for them. So always make sure to transform this challenge into an opportunity. So what are the final thoughts? Now we have new technology in the market called Precision Balance 8.4. You can fit it as fast as a spherical contact lenses. So almost the same time is going to take you to fit a myopic patient -2 and a toric patient with a cylindrical powers. So it's the same time. Also, the same first lens success, you don't need trials. You can just go with the simple tools that you have inside the clinic, and you will have more than 95% first lens fit. The last thing is you are providing a better quality and a better experience for your customers by offering them the full correction in toric contact lenses. So the opportunity is huge. 50% of your patients, they need vision correction as astigmatism with the cylinder of above -0.75. Many astigmatic patients, they don't know that they can wear contact lenses. They are afraid. Nobody told them. That's your chance to show that you can do what no one else did. Toric contact lenses, they are available now for the majority of the patient, even with the high cylindrical power. New toric contact lens technology is very easy to fit, and it fits with a high success rate. The vision, the clearer subjective vision that appears, it influences the overall experience, and that's what you want. Wearers, they report a better comfort when they feel they can see well. So the thing is, always upgrade, and the current users and fit new users on the new technology, and this what will provide a customer satisfaction and growing your business. I would like to thank you all for your participation. It's always an honor to present to you, and we and Amico, as distributor of EyeQon contact lenses in the Middle East, we are honored and happy to be part of this webinar. Thank you so much.
Yes. Good evening, everyone. Ramadan Kareem to all. I am Sana Merchant, and I'm working with Titan Eye Plus in UAE. I'm also a member of United Optometrist Forum. Today now we are entering into our fourth session where our speakers will help us understand the prerequisites for optimizing vision. For this, I would like to now hand over to Ms. Tapashvi Joshi in the Ireland studio to call our first speaker for this session. A very good evening to everyone present over here from Ireland, the only nation in the world with a musical instrument as its national symbol. Hi, this is Tapashvi Joshi as a senior optometrist working with Rivoli Group and also the member of a core UOF team committee. I would like to introduce our first speaker, Mr. Sian Gildia, who is going to enlighten us on the topic contact lens for management of irregular corneas. Over to you, Mr. Sian.
Thanks very much for that introduction. And again, thank you so much for inviting me to speak today at this event. So my talk is on the contact lens management of irregular corneas. So if we look at the early theorists, some of the first mentions of actually use of a contact lens has been in the 1st century AD. By a Roman historian called Celsus. He described using a honey-soaked linen disc inserted into the eye post-pterygium removal. Now, they weren't exactly sure how the operation was carried out, but this is a good few years before any anesthesia, so you can imagine how that would have gone for the patient. Leonardo da Vinci in 1508, in his Codex, he talked about neutralizing the cornea with water, with a water-filled glass bowl. And René Descartes, the French philosopher, he also talked about using a water-filled tube. Thomas Young and John Herschel were really two people that brought it on that little bit further. So John Herschel, he was a physician and a physicist, and he was the first to propose grinding the inside curvature of a glass lens to conform to the cornea. In 1884, there was the development of anesthesia, and this allowed eye molds to be made. And in the Encyclopedia Metropolitana in 1845, in one of the side notes, or an index note, John Herschel described this quote that you can see on the right-hand side of your screen. So should any bad case of irregular cornea be found, he essentially was talking about applying a jelly or a transparent animal jelly in order to neutralize the irregularity. So what is astigmatism? What are we trying to correct when we encounter these patients in clinic? So the word astigmatism, it's derived from Greek, a meaning not, and stigma meaning spot or point. So astigmatism is any condition in which an optical system is not point forming. If we look here on the right-hand side, we can see a map. With irregular astigmatism, the principal meridians aren't 90 degrees apart. There can be often over 2 principal meridians. They're usually, when we're talking about irregular astigmatism, it's usually acquired due to trauma or disease, but also if there's any irregularity in the refractive index of the optical media, that can arise or can present itself as irregular astigmatism. So what contact lens options do we have? We have soft contact lenses, specialist soft contact lenses, hybrid lenses, corneal RGP lenses, and finally scleral lenses. So I'm going to talk a little bit about each one of these in turn. So what are we trying to do with any contact lens fit for our patients? We want a stable lens to allow good vision. We need some movement to allow tear exchange. We want an aligned lens to cornea relationship. That differs slightly then for scleral lenses. We want obviously good vision. That's why they've kind of come into why they're sitting in your chair. We want to avoid any corneal or ocular insult, which is very, very important. And we need to manage the expectations of the patient. This can be particularly challenging if somebody's had good vision, had maybe a traumatic accident, and they often can expect an awful lot because, you know, they had good vision to start with. But I think, in my own opinion, all of those points that I just discussed are really important, but one of the most important things is comfort. There's no point in designing a lens. The best lens gives the best vision ever if it's not comfortable for the patient and they're not going to wear it. All your efforts will be in vain. So this is a contact lens step ladder that I would usually follow when an irregular cornea patient presents into my chair. So what we're going to do is I'll try a soft lens first. If that doesn't work, then we'll go up to maybe an RGP or possibly a hybrid. Then I'll go with piggybacking. I think piggybacking is obviously we put a soft lens in first and then you wear your RGP lens on top of that. I think piggybacking is really underutilized. And then at the top of the ladder, I have my sclera lenses. So if it's possible to use a soft lens, I will. That will be dependent on what the patient can see with specs. So their best corrected visual acuity with glasses. So some classic errors would be maybe using a sclera lens in a very mild case of keratoconus. It tends to be a little bit of overkill. Post-graft lens selection in terms of the actual design of the lens, and then pain relief in a wet eye. So how do these lenses work? What's the mode of action? So essentially, the tear layer that's trapped behind the lens neutralizes astigmatism. So it can neutralize about 90%, excuse me, 90% of anterior corneal astigmatism. It has a significant refractive effect, but it also depends on the cornea lens fitting relationship. Because you have such a strong effect from the actual tear layer, any decentration of the lens can cause a lot of prismatic effect, and that needs to be really considered in order to get a really good fit and good vision. So it uses essentially the perfect refracting surface of the anterior surface of the lens coupled with the tear layer to mask the irregular astigmatism. So soft contact lenses, they're very good for early disease, say in keratoconus, form fruste. Spectacle vision will help make that decision. If they pinhole up pretty well, that can also help. Advantage of using a soft lens is that they're very, very easy to handle. They're comfortable. You have a lot of options in terms of the modality that you use. You might get away with a daily disposable, but a monthly disposable lens is also an option. Because these lenses drape over the cornea, they have a negligible tear layer, and the average thickness of a -3 contact lens is about 80 microns. So I just want you to keep that in your minds until we move on to the next slide, which is specialty soft contact lenses. This picture on the right-hand side is the Ultravision, the Kerasoft IC lens. So the way in which a specialty soft lens works is it's increased center thickness, essentially. So usually the center thickness is about 200 microns, although this can be adjusted up or down. One of the things that you have to remember is that if you're going for a thicker lens, it will be more uncomfortable in the patient's eye, but it has the potential to mask more of the irregular astigmatism because it's trapping a more significant tear layer behind the lens. These lenses are great in terms of the parameter selection that you can use. With these lenses, I tend to go bigger because that can help an awful lot in centration and it can help stability as well. Now, one of the things that you have to be aware of when you're fitting these patients is that the decay of the lenses is usually around 60. There is a limit to the decay on these lenses. You don't get the hyper decay materials like you would in maybe some of the daily disposable soft lenses. So if you're fitting a lens that has a lower decay and a thicker lens itself, you're talking about 200 microns, you have to watch out for any neovascular events, and especially post-graft patients. You don't want anything encroaching. You don't want vessels encroaching into the graft host junction. Hybrid lenses. So here's an image of a patient of mine wearing a hybrid lens. That's it on OCT. So a hybrid comprises of an RGP center with a soft skirt. Now, the these lenses are very good for early disease. I wouldn't usually use them on moderate or advanced cases. I would use mainly a gas permeable or possibly a scleral lens. And the reason or the way in which it works is that the soft lens actually helps to center the GP portion of the lens. Now, one thing you can't correct, you can't put a front toric on these lenses, so that's something just to bear in mind as well. So corneal gas permeable lenses, these are probably the most synonymous with irregular corneas. They have really, really good optics. Comfort can be an issue, and so we have to beware of asymmetric disease. And what I mean by that is that if you have a patient presenting in your chair who has good vision in one eye and then maybe keratoconus in the other eye, if you're going to fit them with a gas permeable lens in the one eye, you have to counsel them an awful lot about the comfort of the lens. Those patients are probably the most unlikely to succeed with a corneal lens, purely for the fact that unless they cover their good eye, they can see relatively well. So that's something that you have to consider. So piggybacking for those patients with asymmetric disease, so keratoconus, say, in the one eye, is a really, really good option. These are just a couple of studies that we're looking at. A corneal lens implies corneal touch. So this study looked at different fitting relationships. So one group were fitted with apical clearance and another group were fitted with apical touch. And after they were followed for 8 years, and after 8 years, there was 32% of the patients fitted with an apical touch fitting relationship ended up with corneal scarring, whereas only 14% of those with apical clearance ended up with scarring. And of course, scarring being a huge indicator or factor being considered when a patient goes for a PK, so a penetrating keratoplasty. The other thing to consider, though, is you can't fit somebody with too much apical clearance, because then you'll get decentration of the lens, and that can cause issues with, say, too much movement, pooling at the base of the cone, and like we said before, that prismatic effect. So one of the things that I'll go through when I'm dealing with these patients or assessing these patients is topography. It's really, really important. So looking at your axial versus your tangential maps, that's going to help your cone classification, which will also help your decision process in what lens you're going to use. I'll look at height maps, and topography and tomography are great for screening visual potential. So I'll go through a couple of these examples now. So this is another patient of mine. This is an axial map. So that, if you took that at face value,
sorry, Mr. Sian, to disturb you. We have a couple of minutes still left.
Yeah.
For the session. Thank you.
Yeah, I'll hurry up now. Sorry. So this is a large. It looks like a large oval cone, but when you put it on the tangential map, you can actually see it's a nipple cone. Again, looking at height differences, if we look here, there's anything over 300 microns of difference, of course, across the cornea. You have a very little chance of succeeding with a corneal lens. So with this patient here, it was straight on to a scleral. Looking at visual potential, if the anterior elevation matches very well with the posterior elevation of the cornea, the chances are the patient is going to see quite well with a lens. However, if we look here at this example, there is a lot of corneal astigmatism, almost 9 diopters. It looks fairly regular in that it's along the one axis, but if you dive a little bit deeper and you look at the anterior versus the posterior float, there's no correlation between them, and this patient ended up not seeing well with a lens at all. So again, scleral lenses, 16 to 23 mil, resurgence in recent years, and improved comfort because they don't touch the cornea. Now, this is a recent PubMed search, 62 indications for scleral lenses. So you can see some of the examples there on the right-hand side. I want to look quite quickly here at sometimes when not to fit scleral lenses. I think people see them as an answer to all the problems, but they're not. Discomfort If they have poor mucus, bubbles, leaks, that's for large 23mm lenses, wettability, or cosmesis. So scleral lenses basically aren't always the answer. This is just a quick case study, final one now. 22-year-old male, he had a -9 bilateral PRK, but he developed a unilateral stromal haze. These are his maps. If you're looking to put a corneal lens on that, you'll get an awful lot of decentration. So this is where the power of a soft lens and piggybacking can come in. If you look at that picture there, that's his eye post-op. You can see it's an oblate shape. If you can guess what pair of soft contact lens I put in, so he was a -9. I put in a +9 soft contact lens. That returned the cornea to its nice prolate shape, and that allowed me then to put an RGP on top of that and have it fitting and centering very well. So some take-home points. BCVA can help determine lens type. The anatomy condition being treated helps determine lens type. They can help avoid or delay the need for surgery, which is huge. And then finally, the life expectancy of a keratoconic is not significantly different to the general population. These people depend on their lenses, and we just have to keep sure that, we're probably going to be taking care of these patients for a long time, and we have to do the best that we can for them. Okay, thank you very, very much for inviting me to speak. And yeah, it's been a great conference. So thank you all so much.
Thank you, Mr. CN, for the wonderful talk. It was indeed insightful for us. Moving on to our next speaker, Mr. Muhammad Abdul Wahab from Pyramids of Egypt. He's going to take us through intraoperative flap complications. Over to you, Mr. Muhammad.
Hello, everyone. I am Mohammed Abdul Wahab, an Egyptian optometrist working as the head of refractive department's surgeries at the International Eyes Hospital in Egypt. Today, we are talking about flap complications intraoperative and how to avoid these complications. First of all, the good LASIK results depends on good preparation and selection criteria preoperative, and good flap intraoperative, and good excimer laser machine calibrated. Is the excimer laser machine good calibrated? Today, we are talking about the flap complications that may happen and how to prevent and avoid these flap complications. The first type of the flap complications is a buttonhole and free cap, complete cut, and dislocation. The first one is buttonhole. How the buttonhole happened? Usually, the suction ring that's fixating the globe during the cut of the flap is fixating the eye from the cornea from the periphery. It's fixating the cornea, the globe from the conjunctiva, and affecting the cornea from the periphery more than the center. And the periphery is pulled up by the suction ring, and the center of the cornea is pushed down. By pulling the periphery up, the center of the cornea is pushed down. So when the blade is cutting the flap, the corneal tissue, it's cutting the periphery with a thickness more than the center, and may cut the center in a partial cut or a full thickness of a buttonhole. So if we used that may happen because they are time consuming. So don't wait for a long time during suction ring. So we are now talking about the reasons of buttonhole. The most common is the steep cornea, because the steep cornea is the fastest occluded cornea during the suction ring. So if it's occluded during the suction and the suction ring is fixating the cornea, the globe and the peripheral tissue of the cornea will occluded firstly, and we are waiting for some few seconds of of time consuming will make the central cornea depress down, and the cutting of the flap will be homogeneous and not homogeneous, sorry, because the periphery will be deeper than the center, so it may lead to a buttonhole or a partial buttonhole. The second reason is the bad quality of the blade or a broken blade. If you are using a blade and by luck it was traumatic blade, or having a trauma to the blade, we have to check the blade before starting to avoid the broken blade may lead to a line in the cornea over cross the whole cornea and may lead to a buttonhole or a partial buttonhole. Or the wrong selection of the suction ring. If we used a larger ring, will make a thinner flap and may lead to a partial buttonhole. The last reason is the long time consuming of suction, as we said before. The second type of the flap complications that may happen intraoperative is the free cap, and there are two scenarios of the free cap. The right one on the right side is the normal diameter of the free cap, and in this scenario we can continue the ablation and continue the procedure to the end. And the other scenario on the left side, the diameter of the flap is smaller than normal and not suitable to the excimer laser. So the exposed area of the cornea is small, so it will lead to unpredictable result if we continue. So it's better to post up this scenario of small diameter of free cap. Why it happened? It happened because the small diameter of the ring that we are using, of the suction ring, it may lead to a very small cut or a very small diameter of the flap, and usually it happens with the too flat cornea and high or large white. If the cornea is too flat and too large, it most probably will happen a free cap. So how to avoid? It's better to use a specific ring, very large ring. It's called LC in Moria, and this ring it's specific for the flat and very high, a very large cornea, or to use the femtosecond machine. And there is an advice before starting the procedure is the marking or the way of marking must be a very easy way to help the surgeon if it happened a free cap and the upside become down. It's better to use a marks that helps us to easily put the flap in the original place, like that picture, a small and larger rings or circles. It's a very simple way of confirmation of the flap positioning after repositioning the flap if it happening the upside down. If we faced a normal diameter of free cap, how to avoid it, to use a larger ring? Why it happened? It happened because the wrong stop of the suction ring we are using. The suction ring has a stopper at the end of it. This number is controlling the size of the hinge. So if we used a wrong stopper in the ring, usually if the stopper was higher than normal in its value, will lead to a small hinge size, or a very small hinge size may lead to a free cap, complete cut. Or ignorance of white. If we didn't look at the white before starting or selecting the ring, suction ring, may lead to selecting a smaller ring that may lead to a free cap or a small or complete cut. And if the suction ring was not centered well on the cornea, if it was decentered toward the superior area, it will lead to also a free cap or a complete cut. A suction loss at the end of the cut, if the microcratome was arrived to the final destination of its direction, and the suction loss at that moment, it will lead to a cutting of the flap, so it will be a complete cut. The next complication is the incomplete cut. Usually, it happens because the decentration of the suction ring towards the inferior area, so it will lead to a very large hinge or an incomplete cut, or the wrong stop of the stopper of the ring. If the value of the stop was low, so it mean that this hinge will be larger than normal, so the hinge will be larger, or it's looks like incomplete cut, or the microcratome was stopped before arriving to the end by any obstacle in its direction while cutting, or the speculum was crossing it to reach the point of the end, or squeezing of the patient. The last one is the dislocation of the hinge position. Usually, the suction ring is fixating the eye, and the microcratome is cutting. The microcratome inducing a reversed rotation of the suction ring. So it must be holded very strong to prevent the rotation of the suction ring and dislocation of the hinge position. And what is the complications that may happen if the hinge position was rotated? Maybe the axis of the astigmatism is horizontal, and the suction ring, if it's rotated, the hinge position will be also horizontal. So some of laser will be some of the hinge will be exposed to the laser, so it will be unpredictable result, and also may lead to a flap striae or dislocation in case of highly squeezed patient post-operative and not wearing a contact lens. And next, another type of the flap complication intraoperative when using the femto laser machine. It may lead to a buttonhole. It's a very rare, but it may happen because the vertical gas breakthrough in case of thin flap thickness and not homogeneous tear film. So it's better to put an eye drops or use a wet sponge to make the tear film is homogeneous before starting the docking. And the other complication from the femto is the incomplete cut. In case of suction loss during the cut of femto, during the docking, if it happens a suction loss, it may lead to incomplete cut and will be postponed and don't complete this procedure. When it's not recommended to use the femto flap, in case of there is a corneal opacity, especially post-keratoplasty. But there is an exception. If the graft was wide or large diameter, we can use the femto machine to make the new flap is a smaller diameter and inside the old graft. And also, we can use it. We can make a new flap deeper than the old flap if the patient was did LASIK before. And it's recommended in the too steep or too flat or thin corneas, or too large or too small white of the cornea. And in case of redo, to prevent the incidence of epithelium ingrowth. And the FS200 has an advantage in this case that you can mark the boundaries of the old flap circularly and recenter the new flap to be inside these marks using the overlay to make just side cut and must be smaller diameter than the old flap. Thank you very much.
Thank you, Mr. Mohammed Abdul Wahab, for an amazing talk. And guys, after having an amazing world tour, we are back to our very own UAE. And let me introduce our next speaker, Dr. Aisha Al-Dinhani, who is going to enlighten us on the topic corneal imaging prior to refractive surgery. Over to you, Dr. Aisha.
You can start, doctor.
Okay. Hello, everyone. Thank you for the invitation. Today, we'll discuss a little bit about the basics of corneal imaging prior going to a refractive surgery. This is our objectives for the day. We will discuss the types of imaging we have, and we will focus more on the tomo and topography, the indications of imaging prior to the surgery, the interpretation, basics only, and some examples of artifacts that needs to be detected by the optometrist. Now, in the past decade, there have been a lot of development in the corneal imaging in the field of ophthalmology. We have a lot of machines in the clinic now that help us understand the cornea and read about it in a different manner than examining it with a slit lamp. Examples of that, the topography, tomography that we will discuss further about, the specular microscopy and the OCT. The specular microscopy, we use it in our refractive surgery, which is the cataract surgery, which gives us a morphologic review of the endothelium of the cornea. The OCT, it's a cut through the cornea, and it takes images of all parts of the cornea that help us read the cornea in different perspectives and look at different structures of it. It helps as well with the contact lens fitting, as we said before. Now, the topography, it's an idea that depends on the Placido disc analysis that helps in reading the anterior surface of the cornea only and calculates the rest of the layers. As we can see here, the most common machine that's used is Orbiscan 2Z, one of the machines that use this technology. The topography, we can say it depends on the Purkinje images of the cornea, where these reflective, I don't know if you can see my marking here, these are reflected in the cornea surface and back to be read by the machine. If they are close to each other, that will detect steepening. If they are further away from each other, that will detect flattening. And if they are irregular, not parallel to each other, that will detect an irregular astigmatism. But this is only for the anterior surface. While tomography, it's a newer modality which depends on shine fluke images, which is a camera that rotates and takes multiple images of the cornea all around. And this tomography gives us more details about the anterior surface, the posterior surface, the relationship between these two surfaces, and gives us a 3D structure of the cornea. Now, the tomography have more advantages than topography. It gives a higher resolution of the entire cornea, including the center of the cornea. It gives the ability to measure the corneas with severe irregularities, such as keratoconus. It calculates the pachymetry, which is the thickness of the cornea from limbus to limbus. It also provides a wavefront analysis, which gives us an idea about the higher order aberrations the patients have. Now, when do we do these images? Basically, for every cornea patient that goes into a refractive surgery, for preoperative and postoperative assessment. The preoperative assessment to determine whether the patient's corneal shape will allow the surgery or not, and determine the surgical parameters as well. It will aid in selection as well in the IOL for the patient with corneal astigmatism and who have had a corneal refractive surgery prior IOL calculation. Now, the basic interpretation that we have to learn about, there are 4 maps in tomography, which is the pentacam that we use. These 4 maps, we have to read them all combined together and one reading that gives us an interpretation. there's something called the axial map, which is the anterior surface of the cornea, elevation maps, which is the elevation of the anterior and posterior surface of the cornea, and then the thickness map, which is the pachymetry map. We'll look into them one by one. The anterior sagittal curvature map. The anterior sagittal curvature map, it represents the anterior shape of the cornea. There are different patterns that will appear. For example, here we see an example of a regular astigmatism that's presented as a symmetric bow tie in both sides, whether it's with the rule astigmatism, against the rule astigmatism, or as in this example of oblique astigmatism. There are some irregular patterns that might appear also in the anterior sagittal curvature map. And these patterns, for example, like an inferior steepening, the red indicates a steepening or elevated K readings, okay? While the yellow is lower, K readings. Different shapes of irregularity as well. There is the asymmetric bow ties with inferior or superior steepening, irregular shapes, crab claw appearance, butterfly appearance, or completely irregular. From this axial map, we can move into the elevation map. The most common shape that we can see, the elevation map with a patient with astigmatism, is an hourglass appearance, which is irregular astigmatism. Elevation maps depend on the idea that compare the elevation of the cornea compared to a reference surface. The reference surface in these cases being the best fit sphere of the lens that is created by the machine. So whenever we see a positive results, that says an elevation, negative results, which means a depression in the corneal side. Now, the pachymetry map, it measures from limbus to limbus the thickness of the cornea. It gives us the three most important areas of the cornea: the thinnest location, the apex of the cornea, and superior-inferior relationship of the cornea between the steepest points. And we have to compare all of these together in order to identify what's the problem. Now, these are different pachymetric maps, like a dome shape. If we see an inferior thinning in the cornea, that would be a bell shape, which represents a PMD. We can see a complete thinning from limbus to limbus, which is presented in keratoglobus, droplet pattern, which is a central thinning as well. Now, some examples of artifacts that need to be identified by the optometrist. There's something called hotspot. If we see in the axial map an area of steepening that is located inferiorly, whether it's light or severely elevated K readings, we have to ask the patient whether they wear contact lenses or not, whether it's soft or rigid contact lenses. That will indicate a possibility that this patient did not have irregularity, but he was wearing his contact lenses prior to assessment. So we need to stop the patient from wearing the contact lens. In case of soft contact lenses, we have to ask them to stop wearing it for a week before the assessment, and rigid contact lenses for 2 weeks prior to the assessment. And this image will disappear then. Another example is misalignment. We compare these two images, they go to the same cornea. And the initial one, the axial sagittal map, the elevation maps, and the pachymetry maps all indicate an irregular cornea, while after realigning the patient to the machine, it behaves as a normal cornea without any irregularities. Now, these are only for practices. What's your diagnosis? If you see an axial map with central thinning, elevation in the posterior and anterior surfaces in the center of the cornea, and very thin cornea in the center at the apex, that indicates a case of keratoconus. Okay? Another example, if we assess this patient, is he able to wear to have a toric IOL insertion or not? We can see from the axial map that this astigmatism is irregular, bow tie. The irregularity also presented itself in an elevation in the posterior surface of the cornea, and there's the apex have been away from the center of the cornea. deprivated from the center of the cornea. So it represents an irregular astigmatism, and in these cases, we cannot implant a toric IOL. Thank you, everyone, for your attendance.
Thank you, Dr. Aisha. It was indeed a very wonderful session. Now, I would like to invite all our speakers for the panel discussion, Mr. Sian Gildia, Mr. Mohammed Abdul Wahab, and Dr. Aisha for the panel discussion. Mr. Kiran K. Challa is going to chair the panel discussion. He's a General Secretary of Alumni of LVP Optometrist India.
Hello, everyone. That was
Over
very
to you, Mr. Kiran.
Hello, everyone. That was very insightful speakers, and we have wonderful knowledge on that. And before going to the talk, I would like to thank organization UF and Kamal for the opportunity. And I don't have much questions, but as panel, I have to ask few questions for you. Sian, I would like to ask your approach, the ladder approach, right? So usually I also go in the ladder approach. I have one question to you, like in a clinical scenario, when you handle hybrid lenses, what are your
Yeah.
challenges basically?
What are the challenges in handling the lens itself?
Hybrid lenses.
Handling the lenses isn't too bad, but the main thing that patients would struggle with, I feel, is removal of the lens.
Okay.
So they can be quite slippy, and they can be difficult to take out for some patients, but with good counseling, and they can get over it. So a small grip on the lens and really dry fingers really helps. But yeah, look, they're very good for people playing sports as well. Sometimes they'll wear their RGPs or a piggyback, and then if they're out playing sports, they might put in a hybrid for an hour or two and then take it out again. So
And my other question is like, what is your favorite choice on your ladder? So you have to decide based on your patient pattern, or you decide based on their their clinical acumen and everything.
yeah, I wouldn't have a favorite lens, so to speak. It all depends on the patient in front of you and what you think is going to work the best. I mean, I just think it's when you're dealing with these types of patients, it's really important to be able to use all the different lens modalities in order to address the problem. So being fixated or stuck down one track isn't a good idea. You have to be able to be flexible and choose the most appropriate lens.
Fantastic. Thank you. Mr. Mohammed Abdul, okay. I learned it's very important for all the team of surgeons and the associate team to take appropriate ensure before the tools be used for the refractive surgery. Okay, you want to enlighten some more tips to the audience?
The types of tools you are using?
Yeah, type of tools to avoid the complications.
Yeah, there's a special suction ring called LC. It's a large ring. It's making a large cut, especially for the large cornea and the two flat cornea. It's divided to using the femtosecond machine, but if it's not available, the femtosecond, and especially we have hyperopic patients and need a very wide flap, so it's better to use a wider ring size. It's called LC from Moria. It's a specific ring. It's not common, but it's very useful in this situation. That's it. That's the special ring. The other suction rings is common at all hospitals, but this one especially is not common like the others.
Thank you. Thank you.
Thank you.
Dr. Aisha, so that your session was very insightful for the optometrist. Okay, I just wanted to give your experience on how to, choosing a right patient for refractive surgery. What is your role of ObScan in selecting a right patient for the refractive surgery? your mic.
Use all machines that you have and interpret them individually, and then combine the reading together and discuss with your optometrist how was the patient doing during the assessment, is he cooperative or not, was the alignment is good, and then reassess and interpret all results all together, and then that will give you a good judgment before you proceed with the surgery.
Thank you. And just wanted to add some more. So I feel tomography plays very important role in today's generation. So to assess the back surface of the cornea itself. Okay, so sometimes we can also pick up early keratoconus and posterior keratoconus also. So this would really help the clinician to understand the judgment in refractive surgery. So what's your take on that?
I think, in my idea, any refractive surgeon should depend or should have a tomography in his practice before going into a refractive procedure with these patients. Because some of the centers do not depend on tomography, but my advice is to go for it.
Thank you. So from my end, I have finished my questions. If any audience, you have any questions, we can discuss.
Actually, we will direct all the questions probably later because we are actually a bit delayed than our normal timing. So we shall move ahead for our next session, that is quiz. So thank you once again, all the speakers and Mr. Kiran for for this wonderful panel discussion. Thank you, all of you.
Thank you very much for the opportunity. Thank you very much. Thank you, speakers.
So guys, we are going to move ahead for the most amazing and the most awaited part for today's event, that is the quiz competition. So let's have a look at the one clip and then over to you, Mr. Sharath.
Hello.
Yeah, please carry on, sir.
Hello, everyone. Happy World Optometrist Day. I am Sharath Raj, optometrist, working as a regional sales manager in Vision Care and Ophthalmology Division. Also, I am the core committee member of UOF. Welcome to the exciting session of the day, EyeQon 2 quiz competition. There will be 25 questions for 10 minutes. After 10 minutes, forum will be automatically submitted. To find, scan QR code or click the link in the chat box. Only first 100 submissions will be accepted. Thank you. Over to Tapasvi.
Thank you, Tapashvi. It has been an amazing evening today with lots of learnings. I hope the powerful scientific session has made an impact on each and everyone present here. As we come to the end of the webinar today, we have gone through the journey of discovery, empowerment, and transformation. We strive to create a world where vision is not just a privilege, but fundamental human right. Happy World Optometry Day to one and all present here once again. I would like to conclude this day by calling upon Tapashvi and Kani to conclude with word of thanks. Thank you.
We stand here today as a proud and a grateful member of UF to express our heartfelt thanks to all those who have made this event possible. My heart fills with a lot of gratitude and respect to all our distinguished speakers for not only sparing their valuable time but also enlightening us with their latest update on the field of optometry and ophthalmology. A very special thanks to our main sponsors, that is Alameen Medical Instruments, also known as Amico, also known as EyeQon, for their impeccable support.
Thank you all once again. For CME certificates, this will be sent to your registered email. This will take about 20 working days. Kindly visit our website www.uof.world for recent updates. And also be tuned for our on-site conference, October's 5, which is scheduled to be on October 11 and 12. Looking forward to see you all there. Thank you all. Good night.